I think we're ready to start. Now, my name is Chris Karapetis. I'm the Head of Medical Oncology and the Director of Clinical Research in Oncology at Sarlan, here at the Flinders Medical Centre. And it really is very special for me to welcome you to what is the Clinical Trials Day of Sarlan Research Week, because clinical trials, for me at least, is a huge part of what I do, and it's a really big part of oncology practice and medical oncology practice. It's an area where we're striving to make improvements, as we are in all areas of medicine, but in oncology we've needed to make big improvements, and we still do need to make big improvements. And clinical trials are really kind of essential to what we do every day. So hopefully through the course of the day you'll learn a little bit about clinical trials here at Sarlan, and you'll see some of the work that, some of the great work that's coming through Sarlan. Now, I'd like to start with welcome to country. We acknowledge the Kaurna people, who are the traditional custodians of the Adelaide Plains, and pay respects to elders past, present and future. We recognise and respect their cultural heritage, beliefs and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. Now, it is my great honour and privilege really to introduce the keynote speaker for today. The keynote speaker is Professor Helen Marshall. Many of you will know that Helen is the South Australian of the Year currently. Her bio is quite impressive. I'll just take you through some of her achievements. She's a clinician researcher and NHMRC practitioner fellow with specialist training in child health, public health and vaccinology. She's a consultant and professor in vaccinology at the Adelaide Medical School and deputy director of the Robinson Research Institute at the University of Adelaide. She is the medical director of the Vaccinology and Immunology Research Trials Unit at the Women's and Children's Hospital and research leader for Vaccines and Infectious Diseases Group in the Robinson Research Institute. Professor Marshall has previously been a member of ATAGI, which advises the Federal Minister of Health on immunisation for the National Immunisation Program, and currently undergoes vaccine evaluations for the ATAGI. She's published over 230 peer-reviewed papers in international journals and has received more than $35 million in grant funding. She's also been awarded the NHMRC 10 of the Best Research Projects in 2016, the SA Science Award for Excellence in Research for the Public Good in 2011, the SA Science Award for Excellence in Research Collaboration in 2019, and was awarded a Member of the Order of Australia in 2022. And Professor Helen Marshall will talk about COVID and COCI clinical trials. Thank you, Helen.
Thanks so much for that very extensive introduction. And it's fabulous to be here and lovely to get an invitation to this, what I think is an amazing research week here at Sarlan. I've certainly had a number of conversations with Andrew Burston about, how we can take some of the learnings here to the Women's and Children's Health Network, where I've just started in the Clinical Research Director role. So I'm going to be talking about clinical trials in a couple of ways, but very much in a very large way at a sort of population level involving the whole of South Australia, as you'll see. So, just to let you know, I am an investigator. I've been an investigator on clinical trials of vaccines, and these are vaccines, as you all know from COVID, that have to be tested for, make sure they're safe and effective before they're actually rolled out in a population program. So I've been involved in that work for a number of years with industry. I don't receive any personal payments from industry. I'm an advisor to the World Health Organisation and ATAGI, as was mentioned, and I'm the principal investigator, or the person that takes all the responsibility for the Be Part of It study, and I hope some of you might have heard of that. I know we've got some students here. You're probably a bit too young, but you'll be interested to hear about how we involve schools in this big study that we did here in South Australia. And the Be Part of It NT study, which was funded by the National Health and Medical Research Council. And I'd also like to pay my respects to the Kaurna people, the traditional custodians of the lands on which we gather on, the beautiful Adelaide Plains, and acknowledge the deep feelings of attachment and relationship of the Kaurna people to country, always was, always will be Kaurna land. So I'm going to focus on two things. One is, which I've entitled Killing Two Cocci with One Vaccine, which sounds like a really strange title, but it's a very exciting area that we've been working on about how you can actually have one vaccine that can protect against two really important diseases for young people. And then I wanted to touch on COVID, but I think we're all a bit over COVID, but I'm going to just talk a little bit about the most recent COVID vaccines and how we're going to approach the end game for COVID. So starting with this idea about having a vaccine that could protect against two diseases, meningococcal disease is one of those. So this is caused by the meningococcus. So there's the coccus bit. And Neisseria meningitis is the scientific name for the bacteria. How it presents, now has everyone heard of meningococcal disease? Pretty much, yeah. How it presents is as meningitis, infection of the membranes around the brain, or septicemia, or both. And septicemia is like a blood poisoning. There are 12 different strains of the meningococcus, 5 main ones that cause meningococcal disease in humans, which is really the A, B, C, W and Y. X causes meningococcal disease in Africa, and there's actually been 2 cases of E in Queensland, which is a little bit unusual. But most of our cases, over 50%, are caused by the B strain. Prior to COVID, we saw about 200 to 300 cases of meningococcal disease a year in Australia. Now, so that's not a lot. It's an uncommon infection, but the problem with it is it has a high case fatality rate depending on which of the serogroups. So for B, it's 6%. For W, it's about 13% of people that get the infection die. We can't stop them dying from the infection, unfortunately, even if we start antibiotics quickly. So it mostly affects children under 5, particularly under 1s, and then 15 to 24 years as another kind of peak increase in cases. And of those people, kids and young people that survive, about half of them will be left with quite a significant complication that is likely to cause disability throughout their life. Now that can be a requirement to have amputation or partial amputation of limbs because during the complication of the infection you get lack of blood supply to the limbs, death of the tissues, and you need to save that person's life, remove that dead tissue. Or it could be deafness or blindness or skin scarring. You sort of think, well, skin scarring, that's not anything terribly much. But actually, children need to be taken back to the theatre multiple times, sometimes up to 30, 40 times, to have skin grafts done. We know that for Aboriginal infants, they're at a higher risk, so 6 times the risk of meningococcal B disease, and in the older children, about 10 times the risk. And the interesting thing about it is, although it's an uncommon disease, the meningococcus is actually quite commonly carried in the back of the throat, around about 5 to 10% in adolescents. So just to show you a little bit about that, you'll see I've circled there where the meningococcus is actually carried in the throat. It's in the back, on the back of the throat. And you'll see in the little graph down the bottom that this is actually showing as age goes up, sort of on the x-axis, and then proportion of carriage on the y-axis. You'll see in children it's quite low, and then in adolescents it goes up. And that's because adolescents interact a lot more with lots of people. Kissing is predisposes people to obviously transmission of saliva and bacteria, and goes up, and then it drops back away as people get older. And there's risk factors for carriage, so your higher rate of carrying the bacteria if you smoke, intimate contact. Going out to pubs and clubs is kind of classically associated with carrying the bacteria, but we're only talking about carrying it here. We're not talking about disease. The bacteria likes to be carried in the throat. It's one of those accidents, really, of nature that it invades the body in an uncommon or a rare situation where there are maybe other factors that allows it to invade. And that's really the way that the bacteria is transmitted amongst people. So the other condition I'm going to talk about is gonorrhea, and that's another coccus you'll see caused by gonococcus, Neisseria gonorrhea. Now, has anyone noticed kind of what's the same about these two in their names? Anyone like to say? They're both from the Neisseria family. So you would have seen Neisseria and in both the slide on meningococcal disease and also on this one, and so being Neisseria meningitis and Neisseria gonorrhoea. So they're from the same family, which means they're very closely connected. This is quite a different infection because this is common. So there are 82 million new infections annually, increasing around the world and in Australia. And women and children really, young infants, carry the burden of disease here. Because women don't actually present with symptoms most of the time. 80% of the time they don't present with symptoms, therefore go uninfected and infections go on untreated. And if you have 3 or more infections of gonorrhoea, you've got a greater than 50% chance of being infertile. So the complications then become pelvic inflammatory disease, infection in the eyes of babies who are born to women who are infected. And again, for Aboriginal and Torres Strait Islander people, they have 24 times the risk. The highest incidence occurs in Central Australia, and there's also the complications of developing antibiotic resistance. So I mentioned they're closely related. They're both Neisseria species, and they share about 90% genetic homology, so 90% of the genes are pretty much the same. But the interesting thing about them is they both inhabit mucosal surfaces. So the gonococcus inhabits the mucosa of the anogenital region, and then the meningococcus inhabits that oropharyngeal mucosa. But what we're kind of seeing is we are seeing the meningococcus causing symptoms such as urethritis, and we're also seeing for some high-risk groups, such as men who have sex with men, that they have had outbreaks of meningococcal disease in these groups. And the meningococcus is even adapting a little bit to being able to live in the anogenital region almost as well as the gonococcus. So there's a bit of mixing going on there. Now, when we think about meningococcal and gonococcal vaccines, there are actually no gonococcal vaccines available. There has been attempts in the past, and at the moment they are trying to develop gonococcal vaccines, but there's nothing available to provide protection to all of those cases that are happening around the world. There are meningococcal vaccines available, as many of you will know, that are recommended for prevention of meningococcal disease in Australia and other countries around the world. So we have the meningococcal ACWY vaccine. It covers all those 4 strains, and it's provided free on the National Immunisation Program for infants and at 1 year of age, and then adolescents, so young people in year 10. So year 10s, you'll be getting your men ACWY. Have you had that yet? Great, excellent. So the other is then meningococcal B vaccine. Now, meningococcal B vaccine is licensed to prevent meningococcal B disease, obviously. It's more complicated to make, it's more expensive to make, and it's more expensive for the government to fund. So it is not provided on the National Immunisation Program at this stage. It is funded for Aboriginal and Torres Strait Islander infants on the National Immunisation Program because, as I told you, they have a higher risk. It is funded here in South Australia for infants and adolescents through the state-funded immunisation program. And again, hopefully, year 10 students have had their meningococcal B vaccine as well. So here in South Australia, we have both those vaccines available, which is great. Otherwise, around the country, there's the opportunity, you get a private script, obviously, and pay for the vaccine. And there's 2 vaccines available on private script. The one I'm going to be talking about is Bexsero, which is the one that's provided through the National Immunisation Program and the state-funded program. And the difference there is this vaccine was developed from a meningococcal B vaccine they had in New Zealand, which they then took and added outer membrane proteins to, which means that the vaccine has got broader protection, as we all know, with the COVID vaccines. Adding variants will actually give us broader protection against different B types. So that's factor H binding protein. These are these NHBA and NADA, and I'll come back to that as we go along. So this is the big study that we did here in South Australia, which is an enormous randomised controlled trial. And it very much involved schools across South Australia and school students. It was called the Be Part of It study because it was all about South Australia coming together to be involved in a large study that was going to be important for influencing policy around the world. And what we were measuring was not only was the vaccine effective in young people in protecting against disease, but did it actually stop young people carrying the bacteria in the back of their throat? Because if you could do that, stop people transmitting it, then you could also have a herd immunity impact as well as protection against disease. I'm not going to go through the study in a lot of detail. It is published already in the New England Journal, so for people who have access to that, and it is on our website, the www.bepartofit website. The publications are all there, so everyone's got access if you would like to read them. So just to tell you briefly, so what we did is we asked all schools across South Australia to be involved in the study. We ended up with 91% of schools in South Australia being involved in the study, which is absolutely fantastic. It wasn't just metropolitan, it was rural, it was remote, it was AP Winelands, it was Kangaroo Island. Everyone got involved, and we had 62% of Year 10 and 11 students in schools participate in the study. What we did is to try and have a look at this herd immunity, whether we can stop young people carrying the bacteria, we actually randomised schools at the start to be a vaccination school or a non-vaccination school, and for those non-vaccination schools, they got the vaccine at the end of the study at 12 months. So we randomised them, and we took a swab at the first day of the study and a swab at 12 months, and we gave two doses of vaccine in between to see whether the vaccine was actually preventing people carrying the bacteria. And we had almost 35,000 young people involved in this randomised control, which is absolute record anywhere in the world to have schools involved. And it's all credit to our immunisation nurses out there in the schools delivering this program to protect people against meningococcal B disease. So what did we show? We showed for the first time in the world the vaccine is highly effective in reducing meningococcal B disease in young people. And you'll see there we've shown a 71% reduction in disease in 16 to 19-year-olds after the study. Now, you might think, why isn't it 100%? Now, when you're looking at this, looking at vaccine impact or reduction in disease, you're counting everybody. So you're counting vaccinated people, unvaccinated people, and the unvaccinated people are more at risk, of course, of getting the infection. So a 71% significant reduction is a very, very good result. And as I mentioned, we wanted to look at whether there was a difference in the carriage, people carrying the bacteria in the vaccinated and unvaccinated groups. And you can see there at the top, there's a column for vaccinated and a column for unvaccinated. You'll see when you're comparing, what we were actually looking at was the disease-causing bacteria that were being carried. And I should explain, about half of the bacteria that are carried, or half the people that are carrying the bacteria, carry what we call disease-causing. So they're one of those serogroups. They're A, B, C, W, or Y. They can cause, if they get into this, they cause disease. Another half is what we call non-disease-causing, or those bacteria don't have a capsule, so they can't actually invade. So what we were looking at there was disease-causing, and you'll see there's no difference between the vaccinated and unvaccinated. So the vaccine wasn't having an effect on carriage of the disease-causing, but you might sort of see where we were talking about all carriage, so that's the capsular ones and the unencapsulated ones. There's a slight reduction in the vaccinated group, so we wanted to try and understand what that meant. And what we found when we did an analysis was that the vaccine was being effective against the bacteria that didn't have a capsule that were being carried, but not the capsular ones, and that's important coming up. About that same time as we were doing the study, some people in New Zealand were looking at whether in a program that they implemented back in the year 2000, because they had an outbreak of meningococcal B disease, they developed a vaccine that was specific to that strain, not a more general one that we have now. And someone had the bright idea, because they're so closely related, let's look and see whether there's any impact on gonorrhoea, if we've seen any reduction in gonorrhoea as well as meningococcal B disease. And what you can see there in I don't think I've got a pointer, but what you can see in that first graph, that red line is following cases of gonorrhoea, and then you can see it drops down and goes back up again. And so that reduction there relates to number of cases of gonorrhoea dropping, and it's comparing vaccinated and unvaccinated people. and another sexually transmitted infection, chlamydia, the rates are still going up, suggesting that the vaccine was having an effect on the gonococcus and reducing gonorrhoea in New Zealand. But as I said, this is sort of an earlier version of the vaccine. So we thought, well, this is very interesting. So what we were kind of thinking with the results that we had, we'd shown that the vaccine was able to reduce carriage of the unencapsulated meningococci that was sitting in the mucosa of the throat. And so that became really important in understanding this impact on gonorrhoea, because the gonococcus doesn't have a capsule either. Even though they're very closely related bacteria, they're both carriage of these unencapsulated meningococci and the gonococcus, which doesn't have a capsule, more closely related meningococci than the disease-causing ones. So this little diagram here sort of shows you the bacteria. And if you think of it, the capsule's that blue, pale blue wall on the outside, and then you've got the outer membrane proteins, the red and yellow outer membrane proteins there. If you don't have that blue bit there, that capsule there, it's much easier for the antibodies generated by the vaccine to actually get to those outer membrane proteins and then cause destruction of the bacteria. So although our findings didn't show a reduction in disease-causing carriage, they showed a reduction in these unencapsulated meningococci, which helped us to understand why they were seeing a reduction in gonorrhoea in the New Zealand study. And not only that, the meningococcal B vaccine actually has an outer membrane protein. I mentioned those 3 outer membrane proteins, and one of those, NHBA, is actually an outer membrane protein found in the gonococcus. So the antibodies developed from the meningococcal B vaccine, one of them is specific to a protein in the gonococcus as well. So there was more evidence around this rather than just looking at the amount of the reduction disease in the population. So at that stage, our health minister decided we'd had a couple of children dying from meningococcal disease, terrible tragedy. We'd had several having multiple or 4 limbs requiring partial amputation, and South Australia had the highest rates of meningococcal B disease in Australia. So our health minister decided that we should introduce a meningococcal B vaccine program here in South Australia for infants and adolescents. And that meant a group of experts brought together. I was one of the people on that to decide, well, who should get the vaccine? And what we did is we looked, and this graph down the bottom shows that red line is actually the average number, average age-specific notification rate of meningococcal B disease. So any age group above that line was included in the program. That's that green line there you'll see. So any child up to 3, and then 15 to 20-year-olds were included in that vaccine program. So this is the biggest program that's ever been done anywhere in the world. Now it just continues for infants and for adolescents, but we had that opportunity for other age groups to catch up and receive the vaccine. We're then asked to evaluate the program, and so we did some kind of fancy statistical analyses around vaccine effectiveness, and you'll see there almost 95% effective if you're vaccinated against disease. And again, that concept of a reduction in incidence of 60% when you look at the whole population, vaccinated and unvaccinated. Adolescents, we had 100% vaccine effectiveness, no cases in anyone that received the vaccine in that age group, and 73% reduction in meningococcal B disease. But I put this graph in because I think, we do all these fancy analyses, but actually I think the graph sort of tells us how effective it was, going from 36 cases in 2017 down to 4. And of course we were interested in the gonorrhoea as well. So we did do an evaluation of vaccine effectiveness, and we found it was 32.7%, which you might think, well, that's a bit low. But actually, I'll show you at the end, if you actually, when they've done the modelling looking at this, you can actually reduce the disease by about 45% across the population. We had a 24% reduction in gonorrhoea in incidence in South Australia in this age group, but it's not significant, and that's because we have very few cases in that age group. We only have about 40 cases a year. So it's really because of our small numbers. So South Australia is the only place in the world that provides protection for babies and young people against all the strains that cause meningitis and septicemia, because we also have the Commonwealth-funded ACWY vaccine. And I've been saying that, but I've just heard the Czech Republic have now introduced an adolescent program as well as an infant program based on our findings that we've published on that. So we were interested then in trying to understand where was a group of young people where rates of meningococcal disease and gonorrhoea were high. And if you actually look at our Australian data, those grey columns are the Northern Territory and all the other colours are the different states. Looking at notification rates across Australia, you'll see the Northern Territory's highest. And not only that, the highest rates are in 15 to 19-year-olds in the Northern Territory. So if you think about that, you're giving a vaccine that could provide very good protection against meningococcal B disease, some protection against gonorrhea. The Northern Territory is really the best place to be doing a study to look into this further. And you'll see we only have about 40 cases in 15 to 19-year-olds. You'll see even in 6 months they've had 197, so higher numbers. And there, that was really just showing you that the highest rates are in Aboriginal and Torres Strait Islander people, and it's in Central Australia. So we applied to the National Health and Medical Research Council. This is a really important study, and they agreed and funded it. And you'll see that we are doing this study in partnership with the Commonwealth Government, the Northern Territory Health AMSTAMP, which is the Aboriginal Medical Services in the Northern Territory, and Women's and Children's Hospital Foundation, NT Pathology, SA Pathology, and the company GSK that make the vaccine are providing the vaccine. And there's the Health Minister in the Northern Territory launching the study for us, where again we're looking at this impact of the vaccine on carriage, pharyngeal carriage, because out in remote communities, the carriage of the bacteria in the throat might be quite different than it is here, and then on gonorrhea. So we're doing a number of different studies. It's not a randomised controlled trial, it's cohort and case control studies and the reason for that is the ideal design would be a randomised controlled trial here, but it's really too difficult to do a study like that across the whole of the Northern Territory. We had great support here, as I said, in South Australia, but it's much more challenging when you're thinking about all the challenges they have in the Northern Territory, but also the remote communities. So we're going with the best designs that we can. So again, we're offering the vaccine to all 14 to 19-year-olds across the Northern Territory. And top end, we've got Department of Education, government clinics, Aboriginal community-controlled organisations, and again in Central Australia, Aboriginal community-controlled organisations. So you can imagine this is quite a large involvement across all of those different organisations. But in addition to what we've been doing, there is mounting evidence now. So we're seeing other studies being published around the world. So in Canada, they've done a similar study providing the vaccine. They've seen a 59% reduction in gonorrhea as well as meningococcal disease. That's our study in South Australia. This is in Southern California, and again, all sort of showing the same thing. So this is really just more recent, up-to-date information at 3 years. So the evaluation we did was at 2 years. This is at 3 years, showing sustained protection against meningococcal B disease in infants and adolescents. And this vaccine effectiveness of 37% now, 30% reduction. But again, it's not significant because our numbers are small. I mentioned to you that they have looked at this and modelled it, and if you have a vaccine that's about that effective, that's effective for 2 to 4 years, you could reduce the incidence by 45%. So that's massive if you're thinking around the world with all those millions of cases of gonorrhea. So we've also got funding now from the Commonwealth Government. They're very interested in this, looking at the long-term effectiveness. It's really important that we measure how effective it is, whether it's a short-term benefit or a longer benefit, whether you might need to have a booster. there's a couple of other studies going on as well, and we're part of a WHO task force looking at whether this vaccine could be used to prevent pneumococcal disease and gonorrhoea. So we have, as I said, mounting world evidence around this impact. And, I think certainly for Aboriginal young people where the risks are higher for both diseases, this would be an important opportunity to close the gap. So I just wanted to explain to you that work that's being done in South Australia, which has had lots of international interest and is helping for policy decisions around the world. But I did think you might be interested in a bit around COVID. So talking a little bit about the COVID vaccine clinical trials going forward to really try and help us understand what's the best way to protect people against COVID and what's the best way to get out of this pandemic. So there are obviously future challenges on our understanding about, how frequently are we going to need boosters? What's the most effective booster schedule? It's important to have the same vaccine for your first 2 doses, but after that, maybe there's a benefit to having a different vaccine. When we have vaccination programs, we like to know that at a particular antibody level, whether you're protected or not, if you take a blood sample. And so correlative protection is really important. People are working on this, but we don't really have correlative protection yet for COVID. Duration of immunity, how long are we going to get immunity from the vaccines? And certainly is something we'd like to improve, the duration of immunity from vaccines. We're going to see new variants, but, as to what they're going to be like, how severe, it's difficult to know at this stage, and also around public acceptance of boosters. We still don't really have there's certainly room to move with boosters and uptake of boosters because it's the 3rd and 4th doses, I'll explain, which are the most important at the moment. So, just a bit more detail about that. So some of the studies that have been done have suggested that if you do have, for your booster dose, if you have a different vaccine type to the one, if you have 2 doses of Pfizer and you have, say, Moderna or Novavax, you may get an improved level of antibodies, but you're also more likely to get a reaction. So it's a bit of a balance there, but the evidence is not strong enough for ATAGI to really come out with a strong recommendation around this, but that's what some of the evidence is showing. There's also these new vaccines. So obviously the vaccines that we've all been receiving are from the ancestral strains, the original strain, but the virus has moved on from there, and now Omicron is, the most common variant causing disease. So companies are now developing these Omicron vaccines and Omicron variant vaccines, which are going through clinical trials. And then you'll probably be aware that we've just had the first variant vaccine licensed in Australia, which is called a bivalent vaccine, and that's got the ancestral original strain and the Omicron strain as well. And then there's other companies are looking at other ways of developing these vaccines against different parts of the virus that may end up being more effective. We just don't know at this stage. And there's also a DNA vaccine that's being developed here in Adelaide. That's, again, a variant vaccine that could be, a very successful booster vaccine in the future. So we have this now second generation of vaccines that are emerging that will induce broader protection and possibly longer. It'd be great to know that we would get longer protection from vaccines rather than to have frequent boosters. So the bivalent vaccine I've been talking about that's got the Omicron and the ancestral strain will be available, I think it's from the 10th of October. At the moment, there's not a really strong indication from ATAGI to have, one or the other. You can still have the boosted vaccines that are available or have the bivalent vaccine, but there's only one licence so far, Moderna bivalent vaccine. And it contains equal amounts of the original strain and the Omicron BA1 strain. And it does have some cross-protection. It does have the ability to provide a bit of cross-protection against the BA4 and the BA5 Omicron variants as well. So it indicates it's giving broader protection. What we don't know yet is, these are the clinical trials, the randomised controlled trials that have been done using it as a second booster dose, so a fourth dose, second booster. What we don't have is evidence about how effective the variant vaccines are. So they do the trials, like I've been talking about, to check that they're safe and immunogenic, but they haven't completed trials looking at how effective that vaccine is against Omicron. But the fact that we get higher antibodies should translate to being more effective. So this is really just showing you some of that from this most recent publication of that variant vaccine, the safety and reactogenicity, or the side effects you can get from a vaccine. Now, the top column in each of those categories is the ancestral original vaccine, and the second row is the bivalent vaccine. So it all looks pretty similar. Maybe you could say when you get down to fever, there's 3% versus 4%, slightly higher with the bivalent, but nothing really to be concerned about from that safety profile. One of the things we look at when we're looking at safety is whether people actually had to attend a doctor because they had a side effect they were worried about or was more serious. So when you compare that, it's 9.8% went to a doctor after receiving vaccine for the bivalent versus 13.8% for the ancestral original one. So again, nothing of concern there. But we don't have data on the more uncommon effects, as you know, the more uncommon or serious ones, such as myocarditis, that have been reported, not only with the messenger RNA vaccines, also with all three, the Novavax vaccine as well. But of course, because the numbers in the studies are quite small, it doesn't mean that there wouldn't be episodes of or occasion of severe adverse events, which you see in the larger studies or when you rolled out to a population program. And this is looking at the immune response when you give the vaccine, the bivalent one, as a second booster. So in the top, you're looking there at, in the first part, all participants, and then they've compared participants who haven't had a previous infection with those who've had a previous infection. And this is looking at antibodies against the original ancestral strain. So you'll see there they are slightly higher for the bivalent vaccine. And then in the bottom row there, you'll see again they're comparing participants, all participants, and then those who haven't had a previous infection, those who have had a previous infection. And this is the Omicron, Omicron variant, that's the one that's causing the problems, or has been in the last few months. And you'll see that if you've had a previous infection, you get higher antibodies after you've had a booster vaccination. So, as I mentioned, TARGI have sort of recommended with this new bivalent vaccine, it's to be used for people 18 and over. And it's an alternative. They're not, saying it's especially better than the other boosters, but I think that's because we just don't have the effectiveness data yet to really come out strongly about that. I would expect it will give broader protection. The recommendations stay the same about the booster vaccinations, a third or a fourth or up to fourth dose, and then it's better to wait 3 months after you've had infection or a previous COVID vaccine to receive it. So that's a bit of an update about the vaccines. The other is really in thinking about the emergence of variants. So new variants will continue to emerge. We can't stop that happening. We can stop it. We can reduce that happening. And the ways we can do that is actually get the whole world vaccinated. So in countries like Africa, where uptake has been much lower, that's where many of the variants are coming from. And that's because the virus has much more opportunity to cause infection in people and to undergo genetic mutations, and that's where we get a variant. So we need high global coverage, not just high uptake in Australia. And we also need vaccines that are very effective, that provide broad protection and that give longer immunity. There's just less chance of the virus mutating and causing another increase in cases. So what we're seeing is that, and you're probably aware with the Omicron, although people still are hospitalised and still die from the infection, overall it's a milder clinical course, and the virus is actually adapting and changing a bit, so it's able to enter the upper risk airway cells, whereas the original strain was more likely to enter the lower respiratory. So it is changing in its ability to cause disease and type of disease, but we don't know what the next strain is going to do. We just don't know whether it's going to be more severe, less severe. So at the moment, really making sure you've had your third and fourth dose, whatever you are due to based on your age and indication, is really the most important strategy to reduce severe disease, along with antivirals. I mean, antivirals, it's great. We've got antivirals as another tool in our toolkit, but that's really what we need to be doing to reduce hospitalisations, reduce deaths, and try and reduce the variants emerging. And some people kind of think, oh, look, I've had the infection. Why, I must have great immunity now. Why would I need another booster dose? But this is hard for you to see in these graphs. But what they're showing at the top is symptomatic COVID infection, and at the bottom is hospitalisation. And because there are the point estimates, or the dots over this side, are showing that the vaccine is effective in preventing symptomatic disease, even if you've actually had a COVID infection before, and again for hospitalisation. So you'll see there vaccine effectiveness 39 to 65% against symptomatic infection, even if you've had the infection prior to vaccination, and 58 to 90% against hospitalisation or death. So even if you've had the infection, it is still worthwhile having booster vaccination. So there's still a fair bit of research going on. So we're part of the Peekaboo study, which I think is a great name. I'm sure that's how it got funded by the MRFF. It's about having a platform, a clinical trials platform that is established so that you can, as policy keeps changing, as the vaccines change, you can trial those vaccines and those different cohorts of people. It's like instead of having a strict clinical trial protocol that you follow, it's being able to change your vaccines, your intervention, change your cohorts as you go along, but there's a specific way that you can test those outcomes statistically so they're still meaningful. And so we're doing that with the Telethon Kids Institute in Western Australia and University of Launceston in Tasmania. And we're looking at this, at which is the best schedule for COVID vaccination to give the best protection and the safest way to administer a COVID vaccine schedule. So it's really looking at the boosters. What we do is we enrol people who've already had their 2 doses, and earlier on we were enrolling them to have a third dose, and they're randomised to either having the Pfizer or the Moderna or the Novavax. So it's a randomised process, and now we are working our way down to young adults and adolescents, and then we'll be enrolling children and young children. And we're hoping at the end of the study that we will be able to determine what's the best, what's the most immunogenic, what's the safest schedule to use. And the other study that I wanted to mention, because we're working with Salin and Narlan, Witchen's leading this study, but we're very pleased to be partnering with you on this study, which is actually looking at how we can improve protection for pregnant women and children with who have medical conditions who are at higher risk of complications from COVID and flu infections, so we want them to be vaccinated. And so we're using a nudge. Now, a nudge is something that you put in place to try and improve or try and encourage positive behaviours and particularly health behaviours. And we see immunisation as a positive health behaviour. So the way you design a nudge is you co-design it at a nudge-a-thon. And a nudge-a-thon is a real thing. People wonder when I say that, but it is a real thing. And what you do is you have the patients, so the pregnant women, obstetricians and hospital executive all in the room to design a nudge that could be used in a hospital setting for pregnant women who attend the hospital, for children with chronic medical conditions who attend the hospital, to encourage them to get vaccinated and be protected. So we are just about to, we've developed our nudge, which is actually a series of text messages with videos of obstetricians, paediatricians encouraging pregnant women or medically risk kids to get vaccinated. And we're just about to start the randomised controlled trial. So again, it's another use of a randomised controlled trial in maybe an unexpected way. So nudges are really important because they can improve behaviour, but you actually have to test them to see whether they work, because you don't want to start implementing something in a hospital where you haven't actually trialled it to check that it works. So just to summarise all of that really around COVID, we're still going to see variants emerge until we've got high global immunity. Public health measures are still really important. Good hygiene, so important, keep you safe from all sorts of infections, but especially COVID. And there's new generation of vaccines, which we hope will broaden and increase duration of immunity. So I'll stop there, and just to thank all our partners for working with us on all the research that we're doing, and thank you very much for your attention, and happy to answer any questions if we have time.
Thanks, Helen. We do have time for questions, so I'll throw it open to the audience. Does anyone have any questions for Professor Marshall? Yeah. David? It's a microphone. If you have a question, the microphone will come to you.
Thanks, Helen, for a great talk. Yeah. I mean, you mentioned the importance of having a third dose, which I prefer to call it a third than a booster.
Yes, it's much easier to call them by numbers, yeah.
But, over 25% of our population who should have a third dose haven't had a third dose. So where do you think we dropped the ball with the third dose?
You mean we just go straight to a fourth dose? Or
no, there's almost a quarter of people that haven't had a third dose.
Yeah.
Who should have.
So we need.
And we know, it's absolutely clear that there's no Omicron antibody after 2 doses, and the third dose gives you Omicron antibody and broadens the immune response out a lot. But we still have 1 in 4 people who haven't had that. So what went wrong?
Why do we think that's happened? Oh, look, I think it's a combination of things. I think as the disease severity's changed, I think people are less concerned about becoming infected themselves. I think some of it that has been, there's mistrust about, government vaccination programs and all the social media that's, been incredibly negative. As to what we can do about it, I think it needs consideration of nudges. How do we actually encourage people to get vaccinated? Is part of it access, not just attitudes? We did some work back in about a decade ago because, there's obviously children that don't receive their vaccines. It's about I think it was about 7% of children were under-vaccinated or hadn't received any vaccines, and people would just assume it's, anti-vaccination or hesitancy. But actually, 86% of those children who were unvaccinated it was access problems. It was single parents working 3 jobs, couldn't get to the GP. It was large families that was difficult to monitor who had their vaccines and were they up to date, when you've got, 8 kids or whatever. It was people that don't engage well with health services. So a lot of it, to me, is just making it easier for people to get vaccinated as well. I think the mobile vans were really important, particularly in getting to groups where there were, culturally and linguistically diverse groups, where they were having difficulty accessing, the vaccine. And so I think I think you need to understand who those 25% are. They certainly are younger people. We know that the rates are much higher of uptake in the older age groups where maybe it's about perception of disease. But I think we have to do all we can to really work out who it is. Is it easier? I mean, I know they're sort of closing down the vaccination centres as well because there's not a lot of people attending. But we've got to be really nimble with this, because if we have a nasty variant come through and everyone's got to get, the bivalent vaccine or whatever, So I'm not sure that I've got the complete answer for you, but I think access is really important. Messaging is so important. Nudges or making it easier for people to get vaccinated is, I guess, some of the areas we need to be continuing to think about.
Can I ask, you sort of mentioned that there about getting to the population you need to get to. With the meningococcal B vaccine study, do you want to maybe just talk a little bit about the considerations and challenges about getting the meningococcal B vaccine to particularly the Aboriginal and Torres Strait Islander population that you're probably really aiming to get to?
Yeah, it is. And absolutely, that's been a challenge. And it's really unfortunate we didn't get the study started before COVID hit, because if you can imagine all the misinformation that happened out in communities with Aboriginal people and the mistrust, and that's all had to really be built up again. And so what we did sort of early on, it's a completely different study to what we did here in South Australia, but we very much listened as much as we could and did as much as we could in the ideas that were being provided to us by particularly schools, say in Central Australia, where there's a high proportion of Aboriginal young people. I went in and gave a talk, but my talk was, I wasn't using the right language. So I learnt, quite early on, even though I thought it was appropriate to the age, it was not appropriate, or it was not as easily understood, I guess. So what they suggested was making a video. So we made a kind of a animated video to explain, and that was very well received. We did we put information out in different languages, Aboriginal languages. We couldn't do them all, but obviously as many as we could across Northern Territory. We've employed Aboriginal nurse and liaison specialist, and in the communities we've actually employed community liaison officers as well, Aboriginal people, to actually show the nurses around and take them to the school and where young people are. So it's been a complete, as you say, learning experience for us. It was, so much easier to do this study here in South Australia, where we have a lot of infrastructure already available. It was kind of starting from scratch in the Northern Territory.
And just on that study quickly, the age 14 how do you decide on what the right age to start the vaccine? Yeah. So the indications are generally, so the age range is, where you've got an increased risk of meningococcal disease is sort of 15 to 24. But we included, again, their schooling's a little bit different. We included the year 9s to 12s. There's giving it it was really just, I guess, to give more opportunity going from 14 to 19. So you want to get the vaccine in before the rates go up. Yeah. Get this question.
Hi, Helen. Lovely to see you
good
down
to see
south.
You, Claire. I did all these familiar faces. Wonderful.
So, lovely work, and obviously the Peekaboo study is very exciting to me.
Yeah.
But what about Men B? Is it possible, because infants obviously are highly at risk, is it possible to vaccinate pregnant women?
Yeah, that's a really good question, and I think it's one that sort of needs some consideration. There is, at the moment, it's like any vaccine. I think COVID's been really interesting because it's kind of opened up the whole conversation about vaccinating in pregnancy. People are always concerned because, it's a developing baby, but really these vaccines are a bit of protein and adjuvant. It's theoretically, the ones that are a risk are live vaccines, a potential risk. But again, so a lot of the time although you're trying to do a clinical trial and avoid pregnancy, obviously a lot of the time women do become pregnant in a clinical trial. I know for HPV vaccine, I think they had 2,000 young women actually get pregnant when pregnancy was an exclusion. So there is data emerging on a lot of these vaccines. I know in South Australia we had 4 young women get pregnant who'd been vaccinated in the study or had normal 3. We were able to follow up 3 of them, normal deliveries. There's no reason to think that there would be a safety issue. And again, it's like pertussis, try and get in early, because the highest rates are in those first few months. And if you can't start your men, and that's why we give men B vaccine at 6 weeks, not 8 weeks, trying to get in as early as possible. But it's a really good point.
And take advantage of the wonderful placenta.
Yeah, that's right, exactly. Claire, international expert on placenta physiology and.
Is the platform design trial that you mentioned just a national project, or is it international?
No, it's national. The UK did something similar, the ComCov trial, where they looked at different schedules. But this is an adaptive trial design where you can stop arms if you need to and introduce new arms. So it's quite nice. But so it's Western Australia, South Australia, and Tasmania, and we all put in for a MRFF. That's how it's funded.
We do trials like that in oncology now, and they certainly streamline the development of new drugs.
Yes.
But as you come in with a new vaccine, are you needing to reapply for ethics approval for them?
Oh, yes, definitely. Yeah. So some of them, because they're licensed vaccines and they're indicated for most of those age groups, we did actually have to do a CTN, a clinical trial notification, for the adolescents receiving 1 booster, because that wasn't a recommendation when we started. And now, as we go into the younger age groups where there isn't a recommendation for a booster yet, but it's part of our clinical trial, we have to get, obviously, ethics approval, but also, clinical research, clinical trial notification, CTN.
Yeah. And just another thing on the vaccine trials, what about the long-term monitoring? How long do these trials typically kind of follow up patients for?
For our vaccine trials, usually, 6 to 12 months generally. So you've got good safety data out to 6 to 12 months, but it is really important that you have long-term safety data, and we talk about this a lot, but I think in Victoria, the Health Department are going to fund a project to look out to long-term outcomes from vaccines given to children, just to provide some of that evidence, because people always ask that. They say, you know it's okay for a few months, but how do you know it's not going to cause something 20 years down the track?
There are all sorts of crazy things going out, as you say, social media, things about fertility, children and things like that.
Yeah, there was certainly fertility, and we looked at that carefully, and there was and Claire will know too, she was part of that discussion, no evidence of fertility issues with COVID vaccine.
There aren't any other questions. I really want to thank Professor Helen Marshall for an excellent overview. Great work, really, particularly the meningitis B vaccine development, and doing some great work in the northern part of the country, which is very much needed, given those huge discrepancies in rates of infection and the morbidity that it causes. And it was good to see that things are still moving forward with COVID, and we're all kind of looking forward to the bivalent vaccine.
Yeah, I feel a bit more excited about it than maybe the Targi saying, it's an alternative. I think, no, that's the one I want.
I think people might be lining up again.
Next booster, 5, 6,
Thank you so much. Thank
you.
Again.
Thanks so much.
Thank you, Helen.
Thank you.
All right, everyone, thank you for joining us today for the Clinical Trials Day free paper session. First of all, we'd like to acknowledge that the land we meet on is the traditional lands of the Kaurna people, and they are the traditional custodians of the Adelaide Plains, and pay our respects to elders past, present and future. We recognise and respect their cultural heritage, beliefs and relationship with the land, and we acknowledge that they are of continuing importance to the living Kaurna people today. So my name is Dominic and I'm filling in for Professor Brioni Kuss, who unfortunately couldn't be with us. We've got a number of talented speakers today, and we're going to start with Dr. Catherine Martorello, who's going to talk about the Acumen study.
Thank you very much. Nice to speak to such an intimate little audience. I'm here to talk about the Acumen study. It's a trial actually that we haven't started yet, but that we will be undertaking at Flinders Medical Centre. And really I'm presenting on behalf of all my co-investigators, and particularly the lead investigator, Professor Nicky Robertson, who is based at UCL in London. So we're talking about neonatal encephalopathy. For those of you that don't know, it's a clinical syndrome describing disordered neurology in the baby soon after birth. Normally we're talking about in term infants, but it also can occur in preterm. That abnormal neurology might present as birth depression, so need for resuscitation at birth, and then ongoing abnormalities of consciousness, tone, reflexes, often seizures, disordered breathing. And that's most often due to difficulties in labour, so intrapartum fetal hypoxia ischemia from a range of complications. That occurs in 1 to 3 per 1,000 live births across Australia and New Zealand, so that was 330 babies last year. It's a real problem. There's some significant consequences for babies with NE. So a third of babies will die despite intensive care, and those that survive will go on to have a range of impairments, including cerebral palsy, hearing and visual impairments, developmental delay, learning difficulties, and sometimes seizures. WHO predicts that annually there's 1 million babies around the world who survive NE to develop disability, whether that's cerebral palsy, learning difficulties, or other problems. Therapeutic hypothermia is the standard of care for these babies in high-income settings, so we actively lower the core temperature of these babies down to 33.5 degrees. We need to start this within 6 hours of birth, and we maintain that for 72 hours and then slowly rewarm. We know that if we do that, we can reduce both mortality as well as disability in our survivors. However, almost half of treated infants will still have a poor outcome despite cooling therapy, and so we urgently need additional treatments for these children. That bit brings me on to talk to you about melatonin. So many of you will have heard of melatonin. It's an endogenous hormone. It's stimulated in response to darkness and inhibited by light. It readily crosses the blood-brain barrier, and interestingly also the placenta, where it is most of your fetal melatonin comes from your mother. In early life, you've actually got very low levels of endogenous melatonin production, but it rapidly increases into childhood. And then after puberty, it falls away, and so it's quite low in adult life, which is why it gets harder and harder to sleep the older we get. And then through the day, there's obviously also that diurnal variation related to light-dark. And so we're talking about levels in the plasma of about 100 picograms per mil. However, if you increase those levels to 10,000 times that, then you can see neuroprotection with melatonin. And that's via a range of different mechanisms. It's multimodal, really. So it's a potent antioxidant. It's got anti-apoptotic effects via the PARP and BAX pathway, multiple anti-inflammatory effects, some receptor-mediated gene regulation, which I don't fully understand despite my best efforts, and also protecting mitochondrial integrity as well. So I've been working at UCL for the last number of years. I've only come over to Flinders in the last few months. And our group has been working on melatonin in a piglet model of hypoxia ischemia to model neonatal encephalopathy. So these are studies that have been conducted between 2013 and 2020, and I was involved in 3 of those. And we have shown protection for melatonin in combination with cooling for a range of different outcome measures that we can measure in the piglet. So that's brainwave activity, magnetic resonance spectroscopy, and also obviously histological brain cell death. And we're not the only group that's been doing that. There's a number of groups that have been looking at melatonin for HIE or NE across rodents, sheep and piglets. And one of my colleagues, Raymond Pang, who's a neonatal trainee and a PhD candidate, did this lovely piece of work to synthesise all of those different preclinical studies over 100 animals and demonstrated that for a range of different outcomes, so brain infarct size, neurobehavioural outcome and histological cell death, that melatonin could reduce brain injury across all those models. So that brings me on to the Acumen trial, led by Professor Nicky Robertson. And so the plan is to bring this preclinical work into the clinical space and to study this in babies. This is the planned PICO for the phase 2-3 studies. We're going to start with phase 1, which I'll talk about today, but this is the eventual plan. So we're looking at term or near-term babies who would be eligible for neonatal encephalopathy, so therefore they have to have moderate to severe neonatal encephalopathy. And for those babies, they'll be treated with therapeutic hypothermia, which is standard of care, but in addition they'll get melatonin, a loading dose, and then some lower doses subsequently for the duration of cooling. And they would obviously be compared with just standard of care, being cooling alone. And the outcome measure for this is a biomarker, a surrogate of outcome, which is MRS lactate to NAA at day 5 to 15. And that's a really robust biomarker of long-term outcome at 2 to 3 years, which has been shown by a number of groups clinically. Obviously, we will also look at 2 to 3 year outcome as well, but the plan is for this short-term biomarker so that we can speed up translation. And obviously, we're hypothesised that the combination of melatonin plus cooling will improve MRS cerebral metabolism compared with cooling alone. So we've been doing some PK studies in the piglet, and we believe that we need to achieve target levels of 15 to 30 milligrams per litre. So as I said, 10,000 times physiological levels in order to see neuroprotection. And we want to get the dose in as quickly as possible. Melatonin really needs to be given at a high dose. It needs to be given as soon as possible after insult. So we've got a big load to start with and then some subsequent smaller bolus dosing that are spaced out after 24 hours by 12 hours. And the reason that we've chosen this this dosing regime is actually to keep the blood ethanol levels low because melatonin needs to be dissolved in ethanol. And so if we dose the melatonin this way, we can keep ethanol well below the FDA blood alcohol concentration limit, which is 0.25. So the load is less than 0.2, and then subsequent doses is very low, less than 0.05, which is sort of like a breatho of 0.005, which most people understand a little bit better. And so this is really what we're heading towards. So we're starting next year. We obviously need to get GMP manufacture of that melatonin in 5% ethanol. And then we're going to move towards a phase 1 dose escalation and safety study. So starting with 4 different increments of melatonin, planning to reach that top level of 20, 10, 10. But starting at lower doses and measuring melatonin and ethanol levels for those babies. And then moving on to a cohort expansion, which is sort of a phase 1 plus. So using the target dose that we've chosen from the phase 1 to see if it's feasible for us to recruit these babies within the time window of 3 to 6 hours after birth and to ensure that we have safety. And particularly working on cross-site harmonisation of our MRS because we're going to have multiple sites involved on different magnets and we want to know that we've got a robust outcome. So we're going to be recruiting babies across the UK, Ireland in Dublin and Cork, and then 3 centres here in Australia will be involved, and that's Monash, Flinders and the Women's and Children's. And then once we have the data from these phase 1 and phase plus studies, we can use that information to then put in our further grant funding for the phase 2-3, which will be a double-blind placebo randomised control trial. And that is all I was going to talk about. Thank you. That was not the slide I was expecting to come up next, but I'll stop there.
Thank you, Catherine. That was fantastic. Do we have any questions in the audience? We have a lot of questions in the audience.
Whoa.
Start with Michael.
Catherine, hi.
Hi.
My understanding with melatonin is there is some reports about malignancy with the use of melatonin, breast cancer in particular. You come across those? Or?
I haven't actually. So I think there's been quite a lot of safety data coming out on melatonin. Quite a number of studies, sort of over 600 patients in meta-analyses showing no safety concerns to my knowledge, but I will certainly do a Google now and look at breast cancer concerns for melatonin because that is not something that I was aware of. And we're lucky actually melatonin has this really low side effect profile. It's used across paediatrics as well, although these are at much higher doses obviously than have been used before. So that's why we're doing that dose escalation study. There have been 5 clinical trials in babies using melatonin for neonatal encephalopathy prior to us. They're all very small. Most are oral doses and most are lower doses, and most of them are single. They haven't had any adverse effects, but that's not looking at long-term, certainly not cancer. So thank you for raising that. I will look it up.
So my first question was the same, particularly with the high dose. Just wondered about long-term toxicity. The second question is more technical imaging related. So, as you said, MRS has to be done, which is not straightforward because different scanners, different field strengths. So, is it all going to be done at 3T? How are you standardising that?
Yes. So, first of all, toxicity question probably the same. We'll do the dose escalation check for toxicity. In the piglet, at least, we didn't see any adverse effects at high dose. We were looking for hypotension specifically. We didn't see it. In the lamb, they just get sleepy. So we'll see what happens with our dose. As to MRS, yes, we are wanting it to be all 3T, and we are working towards that with the team here. By the time we're recruiting for this study, I think we'll have acquired, hopefully this hospital will have its second 3T scanner, I understand, which might make it easier for us to get access. And then we're going to work with the team at UCL, are going to work on standardising, despite using, different types of scanners, and we'll be using phantoms to achieve that, I think.
Sure. Come and speak to me later about that.
Okay, great.
Any other questions from the audience? No? Okay. Well, thank you, Catherine. That was fantastic. We'll move on to our next talk, which is Rajiv Ananthakrishna, who's presenting for Professor Joe Selva. And he is presenting the work. He is presenting the CMR anchor study.
Can I just say, he's presenting for himself. He's actually the first author, so he should be presenting.
Do you have a... Good afternoon, everyone. It's a pleasure to be part of this Sep Research Week. Today, on behalf of the co-authors, I'll be presenting on the utility of cardiovascular magnetic resonance in patients with chronic myocardial injury. Just a brief introduction. Myocardial injury is frequently encountered in clinical practice and, irrespective of the etiology, carries an adverse long-term cardiac outcome. To diagnose myocardial injury, we need to demonstrate elevated cardiac biomarkers, and usually we perform cardiac troponin T as well as cardiac troponin I. According to the fourth universal definition of myocardial infarction, myocardial injury is present when there is elevated levels of cardiac troponin above the 99th percentile of upper reference limit. Depending on the troponin kinetics, myocardial injury is classified as either acute myocardial injury or chronic myocardial injury. And the accepted delta cutoff is 20%. That is, if there is typical rise and fall of cardiac troponin levels with a delta of more than 20%, we label it as an acute myocardial injury. Whereas if the delta is less than 20%, it's considered chronic myocardial injury. It's very important to note that stable troponin elevations, which is reflective of chronic myocardial injury, represents 43% of all new cardiac troponin elevations. And for individuals with chronic myocardial injury, currently there are no definitive guidelines on the most appropriate management. And prior studies have shown that even small elevations of troponin are associated with long-term adverse clinical outcomes. So given the fact that there are multiple etiologies for chronic myocardial injury and given the cardiac prognosis, I think it's important we define the structural phenotype in chronic myocardial injury. And to this end, cardiac MRI is a very useful investigative tool. The role of cardiovascular magnetic resonance has been extensively studied in those with acute myocardial injury, but its utility in chronic myocardial injury remains unexplored till date. So we hypothesized that cardiovascular magnetic resonance can provide incremental diagnostic information in chronic myocardial injury, and our primary aim in this study was to assess the diagnostic utility of CMR. The secondary aims included the incremental value, that is a new diagnosis not previously suspected, and the occurrence of major adverse cardiovascular events. This is a retrospective study, and based on the illustration here, the patients were recruited from our CMR registry database over a period of 6 years. The key inclusion criteria were the presence of cardiac symptoms and at least one value of high sensitivity cardiac troponin T level of more than 14 nanogram per liter with absence of dynamic changes. Patients with contraindications to CMR, those with chronic kidney disease, those with poor image quality or incomplete CMR protocol, and those with a diagnosis of acute myocardial infarction were excluded. Regarding the baseline characteristics of our study population, the mean age was 60 and 60% were male. The most common cardiovascular risk factor was the presence of hypertension. Nearly half of the study population had ECG abnormalities, and the median peak cardiac troponin T concentration measured 40 nanograms per liter. On cardiac MRI, the mean left ventricular ejection fraction was 50%. There was evidence of myocardial edema in 11%, and late gadolinium enhancement was documented in 59% of the study population. CMR provided a cause for chronic myocardial injury in 71%. A normal CMR was seen in 17%, whereas an inconclusive CMR was noted in 12% of the study participants. The most common etiology resulting in chronic myocardial injury was non-ischemic cardiomyopathy. This was followed by ischemic heart disease as well as hypertrophic cardiomyopathy. Cardiac amyloidosis and dual pathology were seen in 4% each. I would like to spend a bit of time on this slide. This slide highlights the incremental value of CMR. On the left-hand side, you have the pre-CMR diagnosis which was considered by the referral cardiologist. The referral cardiologist had access to the base clinical presentation, ECG, routine blood investigations, as well as echocardiography in all the patients. And on the right-hand side, we can see the final CMR diagnosis. So as illustrated in this Sankey diagram, CMR changed the diagnosis in 26% of patients. For example, if you have a look on the pre-CMR diagnosis, 48 patients were diagnosed with ischemic heart disease by the referring cardiologist. However, following CMR, only 24 had a confirmed diagnosis of ischemic heart disease on CMR. The rest had non-ischemic conditions like dilated cardiomyopathy, hypertrophic cardiomyopathy, or cardiac amyloidosis. In those with in our cohort, around 22 patients had a confirmed CMR diagnosis of hypertrophic cardiomyopathy, and of these 22, 14 were newly diagnosed. In addition, a diagnosis of cardiac amyloidosis would have been missed in 5 out of the 6 unexplained LVH cases in the absence of a CMR. Our study also provides a growing support that even those individuals with mild low-grade troponin elevation do not represent a low-risk population. So over a median follow-up of 4.3 years, 32% experienced a major adverse cardiac event. The all-cause mortality was 17%, and cardiovascular readmissions were noted in 21%. The most common indication for cardiovascular readmission was heart failure. This is a table depicting the univariate and multivariate Cox regression analysis. On univariate analysis, a prior history of ischemic heart disease, presence of late gadolinium enhancement, and a new CMR diagnosis were significant predictors of MACE. Whereas on multivariate analysis, there was a trend for patients with a prior history of ischemic heart disease to be associated with a major adverse cardiac event. In those with a definitive diagnosis on CMR, cardiac amyloidosis had the worst outcome. They were 6 times more likely to suffer a major adverse cardiac event. This is the MACE-free survival based on CMR diagnosis. So as seen in the Kaplan-Meier curve, the MACE-free survival was significantly lower in those with an obvious cause for chronic myocardial injury on CMR as compared to those with a normal CMR. So the key findings of our study were CMR provided a cause for chronic myocardial injury in 7 out of 10 cases. prior studies have shown that in the absence of CMR, nearly 50% of them do not have a definitive diagnosis. CMR also changed the diagnosis in 1 out of 4 patients, and this was most evident for those with a confirmed diagnosis of hypertrophic cardiomyopathy as well as cardiac amyloidosis. An interesting thing was the mortality was lower in our cohort when compared to the pre-CMR cohort. So we believe CMR might have influenced management strategies based on the findings. So to conclude, CMR provides useful incremental diagnostic as well as prognostic information in this difficult to diagnose patient population. Based on our results, we believe CMR can impact patient management when it comes to choosing the appropriate investigations, appropriate treatment, follow-up, as well as risk stratification. I believe as there are no prior studies, future multi-center prospective studies should focus on first confirming the findings of our study, and also should help in defining the optimal management strategies for those with chronic myocardial injury. It's also important to note that CMR is not widely available, and also it's an expensive investigation. And I think future studies should also look at cost effectiveness analysis before it is put into routine clinical use. Thank you all for your patient hearing.
Thank you, that was fantastic. I did want to pick up on the point on your last slide about the cost-effective analysis.
Yes.
I wonder what you're sort of anticipating on that, because as far as I'm aware, MRI, it's expensive, it's a big machine.
Yes.
What are you sort of anticipating there in terms of demonstrating effectiveness?
No, we really need to make sure whether it can be applied on routine day-to-day clinical practice. Like what we suggest is to do a cluster randomized controlled trial. Like there are a lot of hospitals which don't have access to CMR. So I think it would be worthwhile doing an RCT of routine standard care, that is non-CMR guided care, as well as compare it with CMR guided care and see how cost effective it is.
Do we have any questions? Yes, Chris?
I mean, I'm curious to know who should be referred for a CMR. And I noticed that in one of the slides, the diagnosis of left ventricular hypertrophy obviously disappeared when you went across the page and you saw the post-CMR diagnosis. There were no more left ventricular hypertrophy as a diagnostic entity. And so I'm just wondering if patients with, because obviously you're kind of determining the cause and you're kind of understanding the pathology, including amyloidosis, which is interesting. So should patients with evidence of chronic myocardial injury with unexplained left ventricular hypertrophy be referred for a CMR? I'm trying to work out which patient should.
I think there is definitely a strong indication for CMR in this case. Usually the LVH, which was done prior referring to CMR, the referring cardiologist was not sure as to what the reason was for left ventricular hypertrophy. The differential diagnosis could be vast, like it could be just hypertensive heart disease versus more serious conditions like hypertrophic cardiomyopathy or infiltrative disorders like sarcoidosis and amyloidosis. So I think if patient has evidence of chronic myocardial injury and unexplained LVH, there's a very strong indication to know the phenotype on CMR.
It's accepted now that that's a fairly high indication.
Oh, yeah. So the diagnosis disappeared across the board because you actually established
the diagnosis.
Yeah, because LVH isn't a diagnosis. LVH is just a phenotype, and that's unfortunately what echo gives you. I think what increasing recognition in our centre and other centres around the world is that certainly if you've got more than mild LVH, in other words, mild plus moderate, and it's unexplained, CMR really distinguishes those different phenotypes. And we've published on that, but obviously time's limited. I have to say, give credit to Rajiv, who's the first author. This paper's just been accepted in European Heart CVI, and also this was presented as a young investigator for Benita, who did this as part of her honours a couple of years ago at SCMR, which is a big international cardiac MR meeting.
Wonderful. Any other questions from the audience? No, I don't think I have anything on Hoover, so we might finish there. Thank you so much.
Thank you, Dom. Thanks, everyone.
Our next speaker is Professor Michael Shanahan, and he will be presenting on the genicular nerve block for pain management in patients with knee osteoarthritis, a randomised double-blind placebo-controlled trial. Thank you, Michael.
I think it's the first time I've been in this building for some time without my mask on, so I feel a bit naked. All right, so we're going to present a trial which has just been completed. It's a collaboration between ourselves in rheumatology and the radiology department, in particular Frank Vojvodic. So osteoarthritis is a very significant cause of morbidity in our community, in fact in most communities around the world, and it has a major contributor to life years lost due to disability, and is a very expensive part of our health service costs. The role of non-surgical treatment is to try and keep people mobile and cut their pain, and genicular nerve blocks might represent a non-surgical and safe and targeted therapeutic approach for intractable pain from knee osteoarthritis, because there have been a small number of case series looking, and it seemed to show some benefit. But to date, there's been no randomised placebo-controlled trials which exist to really examine the effectiveness of this potential intervention. So that was our aim, was to determine whether genicular nerve blocks are safe and efficacious for treating the pain from osteoarthritis. And we designed a randomised trial to examine this question. This is our consult flow diagram. We assessed around 95 people for the study, and we ended up randomising and analysing 31 people in the active arm and 28 in the control group. We took these people from our own patients in rheumatology, and also had great cooperation from the orthopaedic service, who helped us pick patients off their knee replacement wait lists. So we knew all these people had very severe problems with their knees. The people that got randomised were randomised with a study size of sufficient power to detect a 25% improvement in knee pain, which is way above what we would consider the minimal acceptable or minimally clinically relevant change in pain. The active group received 3 injections into the region of 3 nerves, the superior medial geniculate nerve, the inferior medial geniculate nerve, and the inferior lateral geniculate nerve. And they received these injections. They were a mixture of a steroid and bupivacaine. Just note that there is no standard for this injection. So what we used was the cocktail that Frank was already using for this injection in his work. And the placebo group received a subcutaneous injection of normal saline in around these regions, but subcutaneously. This is a little diagram of the innervation of the knee capsule with the various nerves listed here. You can see it's a web of nerves that innervate the capsule of the knee, where a lot of the pain emanates from. And the orange is the superior medial geniculate nerve, the blue is the inferior medial geniculate nerve, and the purpley mauve colour is the inferior lateral geniculate nerve. So Frank was able to identify these nerves under ultrasound and inject them with the cocktail. And we followed up people for 3 months at standard time intervals, 2, 4, 8 and 12 weeks. And we measured their response in a couple of ways. One with a Western Ontario and McMaster University Arthritis Index. It's a very standard index that's used for measuring knee pain and disability in rheumatology, in the knee in particular. We used a very simple and well-recognised visual analogue scale, 100-point visual analogue scale, and we pulled out a different scale to try and get a feel for chronic pain, and that's called the Intermittent and Constant Osteoarthritis score. Again, well validated for people with knee osteoarthritis in knee studies. And finally, we chose a scale to try and get a measure of the patient happiness or satisfaction with the process and with their response. And we used a thing called the Global Perceived Effect Score, which is a 1 to 7 scale for satisfaction. So I'll just run through a couple of the results for you. This is the demographics of our patients, and there is no significant differences between the two groups in terms of age or gender or disease duration, and you'll note this is in months. Most of these people had pain for, in fact, years, and not surprisingly were coming up for knee replacement. And all their baseline scores on the WOMAC and VAS and ICOP scores were the same in both groups. So this is a diagrammatic representation of the WOMAC results. The first diagram is the total score, and there are 3 subscales on the WOMAC score: the pain, stiffness and disability scores. And this diagram, or these diagrams, show, I think fairly clearly, a significant improvement in the group that had the active injection, that is the red line, versus the placebo group in blue, which had a very modest and surprisingly small placebo response. And these improvements lasted out to 12 weeks with a diminution of response over the time period. But even at 12 weeks, the differences remain statistically and clinically significant. So the clinical changes, or the improvement at 12 weeks, is still ahead of the minimal clinical improvement from baseline in each of these measures. This is just the numeric, which explains what I just said. These diagrams show the improvement on the VAS scores, on the ICOB scores, and on the patient satisfaction scores. The VAS scores show improvement again out to 12 weeks. The 12-week mark on the VAS score is not statistically significant, but again, the minimal clinical improvement at 12 weeks in the active group exceeds the improvement scale for the VAS score from baseline. Less impressive on the ICOP score, improvement certainly out to 4 weeks. That's lost at 8 and 12 weeks, so slightly different measurement there. And I'll illustrate the patient satisfaction in a different way, which I think might make it a little clearer for you in a moment. Again, this represents what I've just told you or shown you on the diagram, and the numbers are just reflected in those diagrams. This is another way of showing the Global Perceived Effect Score, which is this patient satisfaction score. And here what I've done is I've divided the active and placebo groups into those that felt either very satisfied or satisfied in each of the groups at each time interval. And the active group is the blue bar, and it illustrates that around 75% of people at week 2 and week 4 in the active group were very happy with what had happened in terms of the intervention. That was still at 50% at week 8 and around 30% at week 12, and quite different from the placebo arm. So this study demonstrates very consistent score improvements in the active treatment arm versus placebo in pain, and also in function on the WOMAC score in particular. And there were high levels of satisfaction or perceived improvement in the active group. We didn't have any adverse outcomes, which was a relief to me. I was a bit concerned that if we start blocking nerves around the knee, people might start falling over, but they didn't. And this does suggest that this particular intervention is efficacious in this group of patients, and possibly may have some significant implications for osteoarthritis knee management in the future, and might become more routine as a strategy, because we've got a lot of people waiting around, waiting for something definitive to be done, and they're in a lot of pain. And this is a very quick and effective way of perhaps relieving that, and cutting down things like narcotic analgesia and non-steroidals in older patients can only be a good thing. So that's where we think this intervention might have a place. We were lucky to get some funding from the Flinders Foundation in order to undertake this trial. And we also really want to acknowledge the cooperation with the orthopaedic service in running the study. And it's a great example of a cross-department collaboration with ourselves and radiology and orthopaedic surgery. And we also really like to thank our patients. It's not an easy thing to walk into a placebo-controlled trial, and all these people willingly did this, and that's just pure altruism. So we thank them for their involvement. There's a couple of references there. And that's all I have to say. Thank you.
Thank you, Michael. That was wonderful and some really promising data there. I wanted to ask you about the act of the nerve block itself. Is that a difficult procedure? You mentioned there were no adverse outcomes, but is it a difficult procedure to actually do, to block the nerve?
It requires some planning, so you need to be doing this at this stage under imaging control. You need to have a sterile field, sterile environment, so it requires some planning. I don't do the block, so I can say it is easy, but it's probably not as easy as it sounds. Both Frank were doing it, but Finn Kai, who you saw on the list of authors, who's a colleague of mine in rheumatology who does ultrasound, very quickly learned how to do the intervention. So I think the learning time is very short. One of the things that we'd sort of be interested in doing is to try and work out whether we might be able to do this without the ultrasound and then just start doing it in the clinic. Some of our other studies on shoulder problems, we've been able to do that. So we do a nerve block at the shoulder, which we just do in the clinic with landmark guidance, no need for an ultrasound or a CT scanner. And we're just wondering whether we'd be able to move this intervention into the clinic. But I think, to answer your question, if you're skilled at ultrasound, this is straightforward.
It's good to know. And my other question, sorry to monopolise the question time, the other question I had was you showed some graphs where it showed there was a loss of benefit up to 12 weeks. Yeah. And I wondered, A, why do you think that is? And B, have you considered maybe following up for longer than 12 weeks?
Oh, sorry, the second part of the question?
So extending the follow-up time beyond 12 weeks.
Yeah, look, I think it's fairly clear that towards the end of the period when we're losing the effect. So I think following out beyond 12 weeks is probably low value. I think we'd probably just rather repeat the block. Why did it happen? Well, it's a single injection of local anaesthetic and steroid, and we expect that the effect would wear off. I reckon a good question is, why does it last so long as 12 weeks? Because, you're only just injecting a bit of steroid and local anaesthetic. And we've thought about this again at the shoulder, and we think because it might be something to do with brain neuroplasticity, and if you stop a noxious intervention for long enough, your brain sort of adjusts, and so you get a longer benefit out of the single intervention, much better than just taking a tablet. And with our shoulder studies, what we see is that the benefit of the repeated injections extends over time, and we wonder whether that might be the case here as well.
Michael, really fascinating. So one of the questions, I don't know, you covered it quickly, but I must have missed it. Did you look at the medication use in the two arms in those first 12 weeks? Yeah. And particularly, was there a significant reduction in opioid use in the active treatment arm?
Yeah, it's a very sensible question, and we really thought about trying to answer this question. The short answer is no, and it was an active decision not to overburden these patients, because they're doing us a lot of service being part of this study. There are already a lot of questionnaires to fill out. They're elderly people. So we just took this rather pragmatic decision not to. It's a
question I'm sure if you're trying to publish it, the reviewers are going to ask. Because how can you say that the placebo arm did not, was there more use of other medications? Yeah. So how can you be sure that the active intervention is the one that was actually making an effect on these outcome measures, which are clearly largely symptomatic related? Yeah.
Well, it's under review at the moment, and I've got the reviewer comments back. They haven't asked the question, so that's good.
Okay, well, you're lucky.
But it's a really logical question to ask, and as I say, we didn't do it because we just thought the burden on these patients was enough. And so it would have been perfectly reasonable to do it. The other thing we thought about asking about was their mood. There's all these questionnaires we can ask about mood, and we just put them aside because we just thought it was too much for patients. So.
Sorry, I think you said there were no adverse effects. Right. So
correct.
Just wondering, mobility. I mean, presuming the pain being less, the mobility would be more.
Yep.
But were there any falls? Was there any sort of
No.
sense of impaired balance or
No,
anything like that?
and thank God. I mean, because these people are pretty frail, some of them. And that was one of the things I was concerned about. We had a bit of a signal from some of these earlier case studies and so on. They weren't having any problems. And just remember, we're not knocking out the total innervation of the knee. And we're not knocking out the quads, which are the knee stabilisers. So we, probably that's why we're not running into trouble. But we did not get a signal at all. Now, it's a small study, so you can't just say, look, everything's fine. Yeah. But no, we didn't. So that's great.
Do you know if this is the sort of thing that the footy players sometimes...
I'll tell you a few stories offline, but yeah.
Any other questions from the audience? If not, well, thank you, Michael, very much for that presentation. We'll move on to our next presentation, which is from Mr. Frank Guerrero. Frank's going to be presenting on overcoming barriers to wound healing in neuroischemic diabetic foot wound cohort using a novel biodegradable synthetic matrix, a randomised controlled trial.
Thanks, Tom. Thank you. Thank you very much to the Sep Research team for the opportunity for me to present a method, essentially, at this point in time of what we're proposing to study. So just as a brief bit of background to the problem, diabetes foot ulceration is a nasty combination of a few kind of pathological, etiological, nasty elements. Microvascular ischemia, obviously wound healing needs perfusion, it needs nutrients, it needs oxygen, and without that we will have a compromised wound healing environment. Diabetes through glycation, elevated blood sugars and tissue. We set up a compromised immuno setting for wound healing, so we have pro-inflammatory environment in these wounds. We have peripheral neuropathy, so these patients can't feel their injuries. When they occur, that means that they're often presenting late when they have their injury, and they're not feeling that they have severe infection as well. And that moves on to the fourth dot point, that there is a high susceptibility for infection for these patients. So there's often a real nasty synergistic tissue loss that occurs in these patients that results in delayed wound healing and a really high risk for amputation. And it just doesn't look pretty, really, does it? Lucky you're not about to have lunch. All right. It's an increasing global problem. It's estimated that every 30 seconds a leg is amputated, and 85% of these amputations are the result of diabetic foot ulcer. So diabetes-related foot ulceration is a global leading cause for major limb amputation, as per Dr. Fakaridi back in 2018. So these statistics may well and truly be increasing. And as we know, with the pandemic, a lot of our patients have been hiding and presenting even later. So I don't doubt that we will see an increasing trend as further statistics emerge. The annual incidence of foot ulceration in patients with diabetes is between 2 and 5%, and that adds up to a lifetime risk of around 15 to 20%. Patients with severe wounds, so they're patients that have poor blood supply, that have infection and a depth of wound that is quite significant either to underlying structures such as fascia, bone, tendon, have a 38% chance of progressing to a major limb amputation within 12 months. So pretty nasty picture to paint there. So understandably, the vascular surgery team and endocrinology team are always looking for a new weapon, a new silver bullet for treating patients with diabetic foot wounds. And we've been playing around with scaffolds. We've been using organic scaffolds and not having terribly great success with those. We believe that the pro-inflammatory state and the high risk of infection, any animal-based product that goes into a patient's wound has a high risk for breaking down and not being terribly successful, and that's certainly been our experience, or it needs high repetition of application. In December 2019, we were introduced to a product that's a synthetic biodegradable matrix that was actually developed here in South Australia by Professor John Greenwood, who's a burns surgeon, who's now retired. And Professor Greenwood came up with this concept of an inert polyurethane matrix that he could put into burns wounds. That would temporise those wounds, allow a new dermis to grow, and then allow time for skin to be grafted, etc. So we employed this, not quite off-label, but nearly off-label in diabetic foot patients. It is approved by the TGA for use in chronic wounds, so we were okay there. And we had our pilot experience, so pilot data of around 23 patients and about 25 wounds in between December 2019 and 2021 October. That our 12-month amputation rates were around 8.3%. Now, reminding that the global meta-analysis data is around 38%. So that we thought that was, there was something in that pilot data. Certainly not a robust trial in any means, but worth investigating further. So I'm being a little bit tangential, but just to clarify what it is that we're playing around with. This is BTM. It's a polyurethane matrix. It fundamentally serves as a tissue scaffold or a proliferative scaffold. It's placed into the wound bed under sterile circumstances, so in theatre. It's stapled into the wound bed or sutured into the wound bed, and it's left in that wound bed, allow tissue to proliferate. It has a sealing membrane, which kind of acts like a skin, reduces fluid loss, etc., but still allows some exudate to come out of that wound. And if need be, you can express, collections and those sorts of things that may gather under there. Once the tissue is proliferated to that sealing membrane surface, the sealing membrane will lift and take it off. Now, the material within there is bioabsorbed, and I believe it breaks down to an alcohol compound and is then just excreted by the body in about 18 months. There you go. It's only about 2 millimetre thick as well. It's not massively thick. Here's an example of a case that we use this on. This is a patient with a dorsum wound. You can see that the infected collection has been nicely excised by the vascular surgeons, and we've got tendon on show. Very difficult to grow or encourage tissue proliferation over tendon and structures like bone. So this was, again, something that we were looking forward to potentially having that happen more reliably. And you can see here's the product that's been in situ now for nearly 3 days. The surgeons elected to hold that in with sutures at this point in time. You can use staples, and you can see that you can get a feel that there's tissue proliferation happening through that. And here is the wound some 3 months down the track now, completely healed, which is fantastic. Excellent outcome for the patient. So the aim of our study is to investigate the impact of BTM on the proliferation of tissue for the purpose of limb salvage in patients with diabetic foot ulceration. And we're going to compare this with our usual standard of care, which is negative pressure wound therapy, or more commonly known in Flinders Medical Centre as VAC therapy. VAC is actually a registered trademark, so that's the generic term for it. And then once we've done a couple of weeks of negative pressure therapy, we move on to conventional wound management, which we also follow in the trial cohort as well. All right. So the method, it's a randomised control trial. We can't blind this, unfortunately. It's a very obvious product when you put it into a wound bed compared with nothing or negative pressure foam. So we're not able to blind it, unfortunately. I've mentioned that the control arm is our VAC therapy and that the trial arm is BTM with VAC therapy for the same amount of time. That's just to encourage apposition, which was a technique that's advised by the company, and it's what we follow to facilitate success. It's a 12-month prospective follow-up trial. We are performing tissue biopsies and collecting wound exudate for the purpose of looking at immunohistochemistry and proteomics, just to see whether we can ascertain whether there are proliferative markers and why we are potentially seeing a difference in patients treated with the BTM versus those that are treated with our usual standard of care thus far, pending, outcomes. So the key outcomes for this are 100% wound epithelialisation, so i.e. the wound gets better and is completely healed, and we'll be looking at rates of major limb amputation in 12 months. I just want to highlight that I'm a late career clinician. I've been nursing for 25 years now, but I'm an infant in context of research. And for me to come off the tools and be able to undertake a PhD is a significant compromise in my life circumstance at this point in time. So this has been my ability to undertake this research in collaboration with the hospital and university has been facilitated by some funding from Polynovo, the manufacturer of the product, Flinders University in Saalin, and they've been able to fund backfill for my clinical role, which has facilitated me coming off the tools and being able to undertake this research 4 days a week, which is just fantastic. And I'm very appreciative of the opportunity to be able to do that. And I would like to see this model in particular for nursing continue to go forward for others such as myself to have the opportunity. Because as you know, by the time we get to this point in our career, we do have clinical questions and it's great to have the opportunity to be able to launch projects to answer those questions. Some references. I'm up for questions.
Thanks, Frank. That was great. It's great to hear your story and your journey into research, and particularly it was interesting to see how something that was used originally for burned wound management now being used for something else. I wonder, you mentioned this is for foot ulcers. Are there any other potential applications for this technology?
Yeah, I mean, all chronic wounds, any wound with a compromised healing wound environment, potentially. Yeah, the company don't know why we're seeing it proliferate in diabetic foot wounds, and that's what we're trying to figure out is, what is it about this structure that's doing that? And I imagine that there would definitely be translatability to other wound types. Yeah,
I'm sure the company would be interested in that.
Yeah. You can imagine all the IP.
I don't want to keep hogging all the question time. That it's really fascinating and it's very interesting. Just a couple of questions. I mean, it seems like you say, the dramatic results in the burns patients, but in this, even the example you showed, it seemed impressive.
Yes.
So I suppose this is a devil's advocate, double-edged question. I mean, do you think, it's ethical to do a RCT in this cohort? And I can go the other way and say, if potential for harm, is there any pre-clinical or pre-human, say, large animal sort of work using this in the diabetic wound model? Yeah. But I'm just wondering, I mean, how do you, it's a hard one probably to answer.
Absolutely. And I'm still undertaking my literature review at the moment, but there are definitely papers about allografts and xenografts that are utilised in America where they recurrently apply these things to these kind of wounds and get mixed success and mixed results. But there is actually no comparable data out there, so we can't consciously say that this is better than our current standard of care, which we assume is good, but the conceptual benefits are very much worth investigating. So I hope I've answered that question for you. Yeah, I think you're right, because I know with the surgical team we've had that occasional dilemma like, well, this foot will come off if this doesn't work. This goodbye leg. But the question has to be asked, and we have to follow it through. And prior to us having this in our arsenal, this device in our arsenal, it was always the usual standard of care. We didn't have an alternative.
I'll just make one very short comment for you about the lack of blinding. As you said, you can't do that.
Yeah.
But because your outcome measures are so solid, I
yes.
think that's going to matter.
Okay.
For clinical trials.
Good.
So don't
that's
worry
good.
about that.
Thank you.
Good. Frank, I think you said your PhD's impairing your life. I just have to say it will change your life, and good on you for doing it.
Thank you.
The rest of your career is going to be fantastic because you've just learned how to look at and answer questions. So sorry, that was just an ad for High Degrees.
Excellent.
But Frank, look, the question that came up in my mind when you're doing this is, at this time, with these patients, what's happening to their vascular supply? Is that a completely separate question, or are you looking at them and saying, okay, as part of this, we're going to have to try and improve their vascularity, we're going to look at them and do bypasses and everything else we can to get these people better? Or are these people past that? And you're just saying, no, this is it, that's all I've got?
Brilliant question. They are meant to be maximally revascularised before they commence participation in the trial, so I apologise for omitting that on my slides. So they are meant to have reached their peak of our ability to revascularise. Yeah.
I just wanted to add to that. So, from vascular surgery, working with Frank, the fascinating thing, the very first time we used this was very much on a foot that I didn't think was salvageable. It was Christmas 2019, I think, and the patient had this incredible plantar foot wound that I'm like, there is no way known that this is going to get better. And I'm like, well, let's bung it on and have a crack. And he's still got his leg, I think.
Yeah.
Which is, it was just extraordinary. Now, he was well vascularised from memory. But it was the extent of the, where the wound was, the plantar surface of the foot's notoriously really hard to heal. And every other time I would have taken his leg off. So there is a lot in this, and I think it's very exciting that Frank's able to explore it properly. But it was fascinating.
Any other questions? No? Well, thank you very much, Frank. Fantastic presentation. Our final presenter for today is Briella Egberts, and she is going to be presenting on the assessment of myocardial injury in patients treated with immune checkpoint inhibitors, a prospective study using biochemical markers and advanced cardiac imaging.
Thank you, Dom, and thank you for the opportunity to speak to you all today. On behalf of all the co-authors, I present this study. It's a very exciting prospective study on immune checkpoint inhibitors. So immune checkpoint inhibitors, or ICIs, increase the survival rate in certain malignancies such as malignant melanoma or non-small cell lung cancer. These are results from a study in 2018 comparing the overall survival rate of chemotherapy versus chemotherapy plus an ICI. It was evident that with the use of an ICI, the overall survival rate was almost 20% greater than chemotherapy alone. This therefore highlights that ICIs have an increased survival rate and a higher efficacy than standard chemotherapy. Concurrent with an increased reliance on ICIs for the treatment of a variety of malignancies, there's been an increase in reported immune-related adverse events. And an example of this, and a severe example, is acute myocarditis. So acute myocarditis can be seen on the cardiac images displayed on the slide. The arrows indicate the patchy nature of the late gadolinium enhancement within the scan. So the frequency of myocarditis in early clinical trials in 2016 was reported at 0.09%, and then later was contradicted in 2018 with a multi-centre study reporting it at 1.14%. And 40% of these cases had a major adverse cardiac event. They found that the median onset of myocarditis occurred at 34 days, and 91% of these cases occurred in 3 months. We used this data to base our follow-up period. So this begs the question of what is the true incidence of ICI-induced myocarditis. It is clear that it is higher than originally reported in clinical trials, and prospective analysis is required to gather more data regarding this myocardial injury, as all data is retrospective in nature. So our primary hypothesis is that patients receiving ICI therapy will demonstrate subclinical myocardial injury in the absence of cardiac symptoms are detected by elevations of cardiac troponin I. With our secondary hypothesis is that patients demonstrating elevated troponin I will also demonstrate myocardial edema and or necrosis on CMR and impairments in strain as detected by a TTE or echo. The primary outcome for this study was that the percentage of study patients who demonstrated cardiac troponin I above the normal range at 6 weeks post-therapy, and the secondary outcomes of LV and RV global cardiac dysfunction, NT-proBNP, reversible and irreversible LV myocardial injury, and the MACE rate, major adverse cardiac events rate. So this study provided a unique opportunity for the collaboration between cardio and oncology. It was a prospective multi-centre study with study centres at Flinders Medical Centre, Flinders Centre for Innovation in Cancer, Flinders Private Hospital and the Lyle Mac. Participants were only recruited from these study centres with no known cardiac history planned for treatment with an ICI. After adherence to inclusion and exclusion criteria, patients signed in a consent form and baseline measurements occurred at the initial visit with the cardiac biomarkers and echocardiography occurring. These were then repeated at 6 weeks with the addition of a potential CMR. The MACE was classified as cardiovascular death, heart failure, hemodynamically significant arrhythmias, or heart block. Important inclusion criteria for the study is we include patients that have an asymptomatic cardiac status, and we exclude patients that had any prior diagnosis of cardiac disease, including myocardial infarction, angina, cardiomyopathy, heart failure, valvular disease, or anyone with a severe respiratory condition requiring long-term therapy. So a full standard transthoracic echocardiogram was performed. Left ventricle ejection fraction was quantitatively assessed using modified Simpson's rule, and the strain measurements were measured by speckle tracking echocardiography by the TomTech software. So global longitudinal strain, or GLS, was measured in a 4, 3 and 2 chamber view. Right ventricular free wall strain was measured in a RV focus view, and then the left atrial strain was measured in the 3 phases of reservoir, conduit and contractile phase. This is the CMR protocol. We measured LV and RV function and global and regional function, diffuse and replacement fibrosis, and myocardial edema. So we screened 79 patients. We had to exclude a lot of patients of 43 because a lot of them did have prior cardiac disease, and a lot of them refused. It's just they're quite a critical population that are getting these immune checkpoint inhibitors. We also screened a few patients that had asymptomatic left ventricular dysfunction that we found that they'd never known if we hadn't screened them for, which is important as well to note. We do have 36 included. Our goal is 40, and we're 2 off that currently, so that's very exciting. 11 patients did have a non-cardiovascular death as a result of the malignancy, and we did have 1 cardiovascular-related death that did occur. So the mean age was 68, 61% of patients were male, and the mean BMI was relatively normal, and the cardiac risk factors are listed. So Wilcoxon signed rank test was used to compare baseline means and follow-up means for all the parameters. The bolder parameters of GLS, RV global strain, RV apical strain and RV mid-wall strain were all significant. It is important to note that a 10% change in GLS is clinically significant, and that occurred in 42% of patients for GLS and just under half for RV free wall strain. Also important to note that in the baseline measurements, the mean baseline was relatively normal for all parameters. So the CMR results, 15 participants had a CMR within the study. 40% of these patients had normal CMR evaluations, and 53 had LGE hyperenhancement. This was primarily seen in the basal to mid-septal segments. And this can be seen as an example on the screen. So this is one of the patients, and you can see that they've got mid-wall LGE in the anteroseptal and the infroseptal segments in the basal slice. 47% had elevated T1 mapping, so evidence of diffuse interstitial fibrosis, and this was again in the basal to mid-septal segments. 1 patient had evidence of myocardial edema, so evidence of elevated T1 mapping, and this was in the mid-infrolateral segment. 1 patient did have a STEMI, so they had a MACE, and 11 patients had non-cardiovascular related deaths. 1 patient also did develop ICI-induced pericarditis and is scheduled for a CMR. So the primary outcome for this study was to assess changes in cardiac troponin I between baseline and 6 weeks follow-up. It was found that there was no significant changes in this outcome. There were, however, significant LV and RV strain abnormalities post 6 weeks of therapy, which may indicate subclinical left ventricle dysfunction in a proportion of patients. Whether this has medium or long-term adverse events is uncertain, but the risk of mild LV dysfunction, even if persistent, has to be balanced with the potential life-saving effect of the drug. It is important to note there was 1 MACE that occurred and another patient developed pericarditis. The segmental baseline analysis and segmental CMR analysis may suggest that pre-existing subclinical myocardial dysfunction prior to ICI initiation may be due to prior cardiotoxic chemotherapy and or radiotherapy. Therefore, CMR findings of myocardial injury most likely correspond with the pre-existing TCE GLS abnormalities and not the ICI cardiotoxicity. And the absence of significant cardiac troponin I supports this assumption. So the major limitation for this study is the sample size. It is a small pilot study, a small sample, and we intend to potentially go further with this. Also, the limitations include lack of CMR results. As I'm sure you can appreciate, these patients are very fragile, so it is very hard to get them to actually commit to a CMR, and a lot of them are really, really, really sick. So it's really difficult to get them in for a CMR, and they also have a lot of complications from treatment. Some of them finish treatment, some of them don't continue treatment, all that kind of stuff. And we also had the MRI unusable for a certain months, which was quite difficult. So from this preliminary data, it appears ICIs are relatively safe. From a cardiac perspective, however, there are some abnormalities with strain and CMR data that need to be monitored. As I mentioned, this work is ongoing and is in our intention to continue to recruit until 40 patients, as previously applied for in our ethics application, and maximise our CMR evaluations. Just like to acknowledge my primary supervisor, Prof. Selva, Rajiv, who spoke before, the clinical trial coordinators, all of the cardiac imaging research group members. Oncologist Chris has done incredible recruiting, and all the echo and MRI departments. Some references. Thank you.
Thank you, Briella. That was fantastic, really interesting. I had a question, which is maybe a stupid question, but do we have any idea about what the mechanisms are in this, how the ICIs are causing?
I think it's all related, immune-related offence, so autoimmunity affecting, so ICIs are they're pretty much enhancing our T cells, so I'll make it easier. So T cells are blocked by tumour cells, so they can't actually kill the tumour cells. So what ICIs do is they actually break that pathway, and that makes the T cells actually able to kill the tumour cells. So then what happens is then T cells go a bit trigger happy and they start eating everything. So that's when the cardiotoxicity can occur from the autoimmunity. Does that answer the question?
Yes, thank you.
Can I just acknowledge and thank Salin for funding this study and all the other things that Briella said about all the people, but this has been funded by a grant actually from Salin. And it's really, small sort of pilot studies like this are really heavily dependent on funding such as this because it's difficult to get a big grant. So, and it's been great. And secondly, to congratulate Briella because this is at the heart of COVID and a very difficult patient group, and she did this as part of her honours. And Michael, just for your information, she's now gone on to a PhD. So we've had one success in a different disease area, but it's fantastic work, and Chris also, very difficult patient group, and these are all the challenges of clinical research. But I think we do find things that are unexpected, like the fact that these are probably pre-existing abnormalities, and you can only really pick these up by doing prospective studies. If you're waiting for the really acute, severe stuff to flare up in case reports, you're only really seeing the worst things, and doesn't truly represent the whole cohort of these patients. So I'll probably stop there.
Any other questions from the audience? Oh, Michael.
Briella, well done. And it occurred to me that, some of these questions about, could these things be pre-existing and so on, could, potentially be answered by having a control group. I realise that, that's a much more difficult study to undertake, but it does shine a light on all of those sort of things, like is this there in the population already, you have to ask what's your control group then, but maybe people who are having chemotherapy that don't go on to have these particular agents. So had you given any thought to, having a control group, maybe in a future study?
We have talked about it. It is obviously very difficult to have a control group because these patients have already had chemo before. Like, these patients are palliative patients. So they've already had chemo, they've already had radiation. So in order to have a control group, it would be really difficult to actually formulate what that control group's going to be. Are they going to be normal patients? Are they going to be patients that have had chemo? Are they going to be, because there's so many different factors. Yeah, that is a good point. And then the other thing is, how will I actually recruit? Will patients actually want to do that? A lot of them are very elderly and they just want to be left alone. So it definitely begs a good question, should we have a control group? But the feasibility of it also needs to be questioned. But it's definitely something we've been discussing.
Yeah, and I think something as sensitive as the cardiac MRI probably is picking up on things that we just weren't suspecting. And I think if we did do screens of more patients who have had radiotherapy to their chest area or chemotherapy, we may find more of these changes at a baseline level. But I just wanted to make a point that we're becoming very familiar with immune toxicity from these immune therapy drugs. But the toxicity that probably fills us with the greatest amount of dread is myocarditis, because it's got a very poor prognosis. Managing acute myocarditis, true blue, florid clinical myocarditis associated with immune therapy is difficult. Long-term morbidity is significant, and the death rate is actually quite high. So anything that we can do to try and pick up on patients who are at risk of myocarditis, or maybe pick up on the sort of early signs of the development of myocarditis, can make a big difference, I think, to patients.
Yeah.
I know it's a kind of an uncommon side effect, but you're right, it's probably more common than we think it is.
Yeah.
Because I'm sure there are patients that have died from immune therapy induced myocarditis that has never been called that. It's been called something else.
Any other questions from the audience before we finish up? No? Okay. Well, I think we'll finish there. Thank you very much, Briella. And that's the end of our session for today. So if you want, you can head outside and there'll be some afternoon tea in Lecture Theatre 3. Thank you.
says recording paused. Is stream inactive? We're going to start the stream. Right. We'll make a start. My name is Ganeshan Kichnadasi, one of the medical oncologists. I've been at Flinders coming up almost 14 years now. It's my great pleasure to host this last session for the Research Week. And it's going to be a really fascinating session. If you look at the presenters and the topics, we're going to take you out of Flinders and go to the regional sector first, and then move around the world and come back to Adelaide, outside Flinders. That's the series of talks we got. So welcoming the country, acknowledge the Kaurna people who are the traditional custodians of the Adelaide Plains, and pay respects to elders past and future, past, present and future. We recognize and respect the cultural heritage, beliefs and relationships with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. It's my great pleasure to introduce the first speaker, Emeritus Professor Paul Worley. Many of you would know him. For those who don't, he is the current Executive Director of Clinical Innovation at the Riverland Mallee Coorong Local Health Network, and also the Regional Director for the Clinical Trial Coordinating Centres. He was the inaugural National Rural Health Commissioner, and many of you would know of him as the Dean of the School of Medicine at Flinders University. Having trained both at Adelaide University and postgraduate training at Flinders Medical Centre, he joined a GP practice in the regional sector and currently works in Barmera and Yankalilla. He's also a fellow of both Australian College of Rural and Remote Medicine and RACGP. Despite his active clinical workload in both rural and clinical practice, he had led excellently to expand the Flinders University rural health education programs, both in South Australia and Northern Territory. He's also the current board director for Royal Flying Doctor Service, Central Operations, as well as our insurance mega. So without wasting much time, Paul, thank you.
Thank you. Nangkarinangi, Nundi Andu, g'day and welcome. It's great to be back. Seeing Lecture Theatre 3 looks a fabulous space, so there's obviously been some really good investment around the place. I just caught up with Michael Shanahan, and I remember Michael telling me that being a rheumatologist suddenly is good. After being really frustrating for so many decades because you would just see patients that you couldn't do anything for, suddenly we now have drugs that actually can reverse and change the course of an illness. But of course, a lot of those drugs, when they start, are only available through clinical trials. So Michael sees a patient from Yalata who he's been seeing once a year, had standard therapies, but unfortunately the disease has progressed despite those standard therapies. And in outpatients here, he says, look, unfortunately things are getting worse, you're going to be susceptible to all sorts of other infectious diseases and pain's getting worse, I can see that. I do actually have a medication that could really help that just suits you perfectly. It's part of a clinical trial. It means that you have to have a supervised IV medication once a week, and we need to see you. So there's no problem in you just getting in your car once a week and coming from Yalata. For those of you who don't know where Yalata is, it's just next to Ceduna. Well, another couple of hours on from Ceduna. So there's no problem in you just getting in the car and coming to outpatients, and we can organise that for you. And the person goes, you know where Yalata is, don't you? Of course, Michael knows where Yalata is. And the person has to weigh up. Okay, so do I put all of that expense into things, knowing that the PAT scheme won't cover me if I'm in a clinical trial because it's research? Or do I just say, I've given things my best shot, I've had a good life, I'll just take my chances? The person says, give me a bit more information. And then Michael suddenly realises, that in order to get this person enrolled in a clinical trial and to get the reports and all of that, he needs to have some hands-on where that person lives. Because, they've got a trials nurse here and they've got all the staff that they need for clinical trials here, but there's no one out there who can do that. Because he says, well, I could probably speak to you over the phone and do most of it. What say I ring your local doctor and see if he can be part of this? Rings up the local doctor and they have that same conversation. So who's going to do this? Who's going to do the consenting? Who's going to actually take the bloods? We need to spin the bloods down once a week after we've had the medication. Who's going to arrange that? How do we know that the medication, when it gets to Ceduna and then to Yalata, actually hasn't been compromised in terms of the cold chain? Essentially, there are step after step after step that block good intentions when it comes to rural and remote patients accessing clinical trials. And that is one of the contributors to why rural and remote patients don't get access to clinical trials. It's one of the contributors to why they have worse health outcomes compared to people in the city who do have access to the latest therapy. And what if Michael decides, Sinead convinces him and says, we've got to have a tree change, a sea change in fact. We're going to go and live in Ceduna. You can be a rheumatologist. There are so many patients there that could benefit from you. So he goes up to Ceduna and he's seeing patients that are referred from all around South Australia because they hear that Professor Shanahan is there. And he sees the same sort of patients that come through to him. He says, I know that you would be able to use this trial drug, but now that I'm practicing out here, I can't give that to you because we don't have all of these other things in place. And he starts questioning, is it really a good move to move and become a country specialist? Many of your colleagues who have made that move to become country specialists feel like second-class citizens because they know what they could be offering for their patients, but they can't offer it. They have to offer second or third generation medications rather than what they're reading about in the papers, what they're hearing about at conferences. And when they discuss things with you at conferences, they may not say it, but they certainly feel at a different tier to people who have the privilege of working in the city. And we know that it actually doesn't have to be that way. That's what the Regional Clinical Trials Coordinating Centre is about. We're not running any research programs. We're helping you run the research programs that can help your patients survive and thrive where they live. So, a bit of the detail. I actually spoke to you in Nuddengerry tongue, working at Murray Bridge. I understand that this land is contested by the Rumanjeri people as to whether it's Kaurna country or Rumanjeri country, but I also acknowledge the Kaurna people who have lived on this land for centuries and centuries, and as we're finding out from the Naracoorte caves, probably millions of years. So this work, and if you look at the team that we have here, and we'll introduce them a bit later, it's part of a national teletrial program, which came out of work that was done in North Queensland to show that if you go from Brisbane to a rural centre called Townsville, your patients can access medications in a safe and effective way. Obviously, this is moving beyond Townsville size populations, but nonetheless, $75 million to overcome the barriers, not to run research, but to overcome the barriers for your research. What does this involve? A very simple process, and for those of you who are in health networks, you'll understand this. You have a primary site where you already have the researchers. Through telehealth, they can communicate with clinicians and patients in satellite sites, and you have more than one satellite site possible for every primary site. So just think of where you already visit in terms of the places that you go, where your patients come from. They can be the satellite sites, FMC, Flinders Private can be the primary site. As I said, the results from Queensland showed that it actually works, and people are prepared to take it up, and they're prepared to access people via telehealth. Now, this teletrial pilot evidence was pre-COVID, when telehealth was something quite radical. We now know it's just business as usual, don't we? So it's not the telehealth that is actually the key innovation here. It's the other bits that go to making a clinical trial work. So the objectives that we have are actually beyond just doing clinical trials, because this is a 5-year program. So we do a 5-year program. Wonderful. We have all these patients enrolled in clinical trials. It stops. Everything stops. And we go back to where we are now. No. So our plan is actually to transform the landscape so that undertaking clinical research is business as usual in rural communities. So the benefits that you all get here by having teaching, research and clinical practice integrated are seen to be present for rural patients as well. So we're going to use this and the staff that we have to support clinical research, clinical researchers and trials, even if they don't fit the very quite narrow definition that we have for funding support. We've made that decision that we want to support people more broadly than that. Hence, our aim is actually a much bigger aim than just implementing clinical trials. You also noticed a thing that snuck in there, which I'm really excited about. Got the opportunity to work in the Northern Territory again. For those of you who work in the Territory, you'll know the expertise that's there. Unfortunately, there were people who thought that there actually wasn't much in the Territory in terms of clinical trials, and South Australia would have to run it for them. We know that's not the case. In fact, in terms of rural and remote clinical trials, they're probably ahead of us in that regard. So it's a good opportunity. But what that means is if you're doing clinics in the Territory, or your colleagues are, then Kintore, Tennant Creek, Alice Springs, Katherine, they could be satellite sites as easily as Murray Bridge or Mount Gambier or Port Augusta. So think bigger than that. In fact, if you're going to Mildura or you're going to Warrnambool or you're going to Broken Hill, likewise, you can think of those sites as being satellite sites. We also realise that we've got to train the workforce. That's especially in rural areas, but we're making this available to everybody. So if you haven't done your GCP training or any of your staff haven't done that, click on this link. It's on our website as well, and you get free access to the GCP training. And there's actually steak knives with this. I'll get to that in a bit because there's more. So our team that we have here, Ben up the back, Jess and Amy, and for those of you who don't remember her, Jenny McCulloch. Is part of the team. So if you need to contact us, actually contact Jenny. You'll recognise her voice and she will know where to go and how to actually make things happen. The other person who's not here, because she's in La France at the moment, you will probably also know, and that's Pascal Detwiller as a academic pharmacist, because pharmacy and supply chain clearly is a big part of making this work. We're recruiting further people, looking for another cluster startup specialist, the person to work with the satellite sites to get all the infrastructure there. And we're also looking at a training and development officer who will be training and developing rural staff, but they can also train your staff. Okay? And we'll get to that more in a minute. In terms of where our staff are going to be located, we already have Pascal in Port Lincoln. I work at Murray Bridge. We have staff in Highmarsh Square, and we are looking at recruiting 3 trials nurses. Remember trials nurses? They're the ones who actually make it work. So we're actually going to recruit them locally in Whyalla, in Renmark Berry, and in Mount Gambier. And we've actually collaborated with the universities so that they are going to be joint appointments and jointly supported by the university. So Flinders is going to support the two in Mount Gambier and Berry. University of South Australia is supporting the trials nurse in Whyalla, and University of Adelaide is supporting a trials nurse to work in general practice across the rural part of the state, because there's a partners grant that you may hear of as well, which is assisting this to roll out into general practice. So opportunities to have those hands on the ground which you need. Now, this is a little bit of the steak knives. We realise that when you put in a grant for a trial, you're basing it around the costs of everybody coming to your outpatients or to your clinic. And if we're starting to engage other sites, there's a marginal additional cost. So we've got funding for that. Essentially, $10,000 for you as a hub, and $700 for every patient who's recruited rurally as part of the trial. What can you spend that money on? Anything related to trial and research. So there's some discretionary funding to support things like if there has to be some transport or you need to do some additional work. But the things that you won't have to do by yourself are doing the ethics supplementary applications, the SSAs, the changes to the SOPs, all of that, because that's what our team does. So that's what we've employed. We've employed the people that mean that you can use what you've already developed and we'll adapt it for that local system. You'll still be the people who have to put your name to it and sign it, but you'll actually have some people, you won't have to use your own trial staff to do all of this. And we'll have the trials nurses as well to be able to provide that support. So we can do a lot of that negotiating with funders and all of that sort of thing to just make it as easy as possible. All the reasons why you never did this for one patient in Yalata before, because it just wasn't worth the time and the energy and all of that. They had to come to Adelaide. So the conditions of funding, which you can see here, that we need to be able to report. I don't think that's a big issue, but we're not taking your data. It's not our trial, it's not our study. We just need to be able to make sure that we can report what's happening so that the Commonwealth Government, the MRFF, know that their money is well spent. So this is us, but these are the people here. Can you stand up just so that people can... in fact, are people looking at this, or is this just audio? Okay, so you better come out. You better come out the front. Yeah. They're a great team. So come out. Please do contact us. And our sense is that a lot of the studies that you're doing, so Jess, Jenny and Amy, and Ben didn't come out, of course, but he's up the back. So if you need to find us in Highmarsh Square, we're next to the Office of Research and report up through the Chief Medical Officer. So it's got support from the very highest levels in government. So open for questions.
Thanks, Paul. I'll kickstart with the question. Oh, got there. Go, Steve. Okay. One of the big challenges, which is around Office for Research and governance applications and approvals. Now we have 10 elections outside Metro. How are you going to circumvent that?
So you want world peace as well. So, I mean, the first question is how do we find out where the trials are? There's no sort of, So there is a one-stop shop that's being developed at the Commonwealth level, which is looking at addressing these sort of issues. Will it still have to get permission at every level? That's part of the negotiation that will occur. We don't have an ideal system, do we? I was at a meeting 2 weeks ago with people from Novavax looking at trialling their COVID vaccines in younger Australians. And interestingly, they said that our regulatory system is actually very attractive for clinical trials. That's why they did a number of their trials. But once you get beyond that big picture regulatory system, the small R regulatory system of having to go hospital by hospital, ethics by ethics and SSA by SSA is just a complete pain in the neck for them. So absolutely we need to do this. It's recognised nationally, that issue that you raise. What we will be able to do is participate in that so that country people aren't left even further behind. Because you can imagine what would happen is that you'd get Salen, Carlin and Witchen, probably not even Narlan, but you get Salen, Carlin and Witchen, who would make sure that everything worked in an integrated way there, but we would all be left. So this way we will be part of that. Just as Jessica, who's now managing this, was instrumental, and Amy as well, in getting research gems. Now, whatever you think about the current state of research gems, we've got people who are interested in that bigger system picture of how do we make things easier.
Thanks. Steve?
Yeah, just at a practical level for the staff who may be employed to run the trials locally, it's going to be really tough for them to be managing a million different protocols from different specialties and in all sorts of different ways. Might be a pharmacological trial, might be a technology trial. You might have only one patient in 20 or 30 different trials, theoretically. So it's going to be tough on that person. I don't know if you've thought that through and whether we can enrol people with specific local expertise in our areas and maybe have them backfilled to help with the trials, particularly in our field, like diabetes technology trials. So they would be really hard to run outside of the area where there is specific expertise.
No, you're right, Steve. There's going to be learning that we do around what trials are appropriate, and Pascal's job in many ways is to look at the protocols and with the researcher make that determination of, is this actually something that we are going to do, or is this something that it'd be nice to, but there's just, even with our resources, there's too many roadblocks. Having said that, I mean, the only person that has a role a little bit like this at the moment in Mount Gambier, like the trials nurse, amazingly underworked. So if we get that problem, wow, that will be fabulous. And if we get to that stage, just imagine how many lots of $10,000 and how many lots of $700 that is, and what that means about, well, potentially we might be able to actually recruit more staff. So what we're putting in place may just be the start. And we may get some more specialised expertise in terms of CGMs or those sort of things.
Michael?
Paul, thanks for that. Thanks to Elaine Pretorius down at Mount Gambier. Is that on? Thanks to Elaine Pretorius down at Mount Gambier, we've at last almost got an agreement for our rheumatology service to actually go down there on a regular basis. So
fantastic.
It's a huge breakthrough. That's taken a decade to do that. But a lot of our trials currently would involve at least one arthroscopy, usually done up here. I guess I just want to know technically, I mean, the limitations to this sort of funding. Can we fly patients up to have something done like that up here and fly them back again? Do we have discretion over this sort of money?
So you have discretion over the funding. Does everything have to be done rurally or remotely? No.
I guess that's the question.
That's the question you're asking. And the answer, if they need a PET scan, then come up here for a PET scan. Okay. If they need the arthroscopy, and the arthroscopy can't be done in Mount Gambier. Now, it might be able to be done possibly in Mount Gambier. And let's see if we can do more of that sort of work. But there are things that you cannot do, absolutely. And so that's absolutely fine. Every trip that we save them is a huge benefit to that person, to their family. And we know that puts a stress on their body, decreases their immune response. They're going to get worse outcomes if they're going backwards and forwards.
Yeah, that's
Just think of the West Coast Eagles, having to do that football travel all the time.
Yeah. Well, that was our principal idea of actually going down there, and it's taken a long time, but it's great. Yeah.
got one other question.
Yeah.
How does success look like for you with this program? Is it number of trials or participants in the trial, quality of studies, quantity of studies?
Yeah, I think success will look like this. When the Minister of Health is in question time, is harangued by an opposition member about the crisis in this town or the crisis in that town in rural health, he or she, and at the moment they're he's in both federal and state, will say, yes, that is a problem, but let me tell you about something good that's happening. And he'll talk about patients who have accessed these clinical trials because they have spoken to him. I think success will look like when we can attract more specialists to work in regional cities and regional centres because they don't feel like they're second-class citizens. Success will look like people who have a cancer diagnosis not having to relocate for the entirety of their treatment. There may still be parts of it that they have to, but they and their partner and their family are able to still run their business. And success will look like regional CEOs having research performance as one of their KPIs.
Well said. Any final questions, comments? If not, thank you, Paul, and wishing you all the success. So the next presentation is from Professor Andrew Burston, who you know very well, Clinical Director, Medicine, Division of Medicine, Cardiac and Critical Care, and also the Executive Director for Research Strategy within Salin. So after returning from a research fellowship at the University of Western Ontario under the supervision of Professor Sibbald, he joined Salin as a consultant intensivist and was the Director of Intensive and Critical Care Unit for a long, long time. In his current role, he has contributed to both the management of Salin's largest division, which is the Division of Medicine and Cardiac and Critical Care, and development of a research strategy that will provide fresh opportunities for Academic Health Sciences Centre. Thanks, Andrew.
Thanks, Ganesan, and I hope I won't be too long here, but I'm really the warm-up act for Sharon Pittman, who I'll introduce as we follow this along. And if you've seen some of this before, I apologise, you can go to sleep for a couple of minutes. But I thought I wanted to talk to you a little bit. We've had a COVID thread through the whole week, and I asked Sharon to come along and talk about Adelaide as a national park city, really, because I think it's an important thing to finish on a very high note, and it's also, I wanted to link it with health, and I said that I would try to do that and make this a bit relevant to all of us today. It's interesting, we've been very fortunate. We've had the Commission here, and it was a great session before. I think everybody who got to it would agree with that, but they were talking about clinical governance framework, but interestingly, there's also a climate risk response that the Commission is looking at the moment, a sustainable healthcare module. And Simon was telling me that he was in Perth last week, and our Chief Medical Officer was suggesting that about 7% of Australia's environmental factors contributing to global warming are in health, and about half of those are in the building. So some of those are from the building that we're in at the moment. So it's really on the radar for us all. So I just wanted to talk a little bit about some environmental factors. And I got a little bit interested in this maybe 20, 25 years ago when I was interested in lung biomarkers, and it turned out that lung biomarkers were closely correlated with cardiovascular risk, and I could not understand that at the time. It was interesting because that meant that the work we were doing might have something outside the intensive care unit, which was my primary interest. So if you have a look at there's a key paper for New England from a long time ago, 1993, and if you have a look there are 6 towns where they looked at the increased in overall mortality rate and the total particles and the fine particles. And if you have a look here, this town of Steubenville, which is this highest one here, which has got about close to 30 micrograms per cubic metre of fine particles, we also call them 2.5 micron particles or microparticles now, is associated with about a 25% increase in mortality risk. Now, Steubenville, I had to look it up, is a steel town in Ohio, so you might just get the sense of that. What happened in Steubenville was they like a number of other areas, improved some of the things that they were doing, and they had a reduction in their microparticles, and this was reported here associated with a reduction in mortality risk. So what are the microparticles in Adelaide? What are they in Sydney? What are they elsewhere in the world? And I looked this up on a particular day. This was on the 25th of August. I had a few spare minutes, and Adelaide was fantastic on that day. We had our microparticles were 0.1, but our 219 average was 6.1. To put that in context, the US EPA standard is less than 12. But the WHO current standard has fallen to being less than 5. So no matter what we had, we were above the current WHO standard. You can see there that Sydney had an average of about 11, even though it was particularly good on that day. And if you went to Wuhan or to Delhi, it was pretty poor. If you travelled internationally and went to London or Paris, Washington, those sort of places, you were being exposed to at least double the average microparticles that you might expect. I won't spend too much time on mechanism because it's a clinical trial session, but the mechanism is thought to be threefold. One is that the microparticles cause inflammation within the alveolus because they're very small. They lodge in alveoli rather than in the conducting airways. But also they're so small, you remember a red cell is about 8 microns, we're talking about things that are 2.5 microns and less. So they can get across and into the circulation and actually have direct effects within the circulation, and that associated with some neurohumoral mechanisms probably leads to changes leading to plaque rupture and this increase in cardiovascular risk. Now that's important for all of us. I looked it up in Canberra when there were the bushfires in Canberra, or the wildfires if you're in America. They reported microparticle levels of 400 micrograms per cubic metre on those particular days, just if you'd like to know what exposure might have been like. And they recorded increased mortality associated with that. That was cardiovascular and respiratory. So, here's a recent paper from California showing that with extreme temperature, 6% increase in excess mortality. With an extreme microparticles, a 5% increase. This is on a particular day, just one day. But if you had the two of those together, say you had a very hot day with high levels of microparticles because you had bushfires in the area, you had a 20% increase in risk, and it was in cardiovascular risk, heart attacks, particularly, and in respiratory risk. So what about COVID? We've just had COVID. What does that mean? So this is an extraordinary study, 75,000 patients from Kaiser in California. And they looked at microparticle exposure at the same time with COVID risk, and I think they were able to show for a 1.5 microgram increase. So remember that we're sitting at about 6 here at the moment on average, but for a 1.5 microgram increase, so it's a minor one, there was a 23% increased risk of hospitalisation, a 35% increased risk of ICU admission, and 11% mortality risk associated with that. So I looked at that and thought, I'm damn pleased I'm living in Adelaide, and I wish we could have a cleaner environment here, but it's pretty good compared to some of these places that we might have travelled to. So none of this is included in any of the epidemiology. Remember, we had Adrian Esterman talking to us about epidemiology, but none of this we've thought about in the epidemiology of COVID and mortality and hospitalisations and so forth. So that brings me up to my last slide, which was a recent paper in Nature, and it's a pretty complicated analysis, but the trouble with when you look at parks is that parks tend to be associated with socioeconomic factors. And so they were able to look at the incidence of COVID, taking into account 3 socioeconomic groups based on proportion of colour. In other words, the African American, that was their major socioeconomic indicator. And so there were 3, low, medium and high proportion of colour. But no matter what you had, the greener the area you had lived in, the reduced incidence of COVID that you had. Now, so that's my thread, Sharon, to bring you into our discussion, to suggest that I think it's important that we think about the environment that we live in. It's not just about our well-being and what happens on a day-to-day basis, when we go for a walk tonight or how we wake up tomorrow morning, but it actually has lots of effects with us. And so I'm really pleased now to ask Sharon to come up to stage in a moment. Now, Sharon has worked in this field for a long time, and she's currently leading the National Park City project. She'll explain what that is to you, but I think we should be incredibly proud, and I'll just say that right now because we're the world's second national park city, and most of us don't know much about that, but it's a relatively recent announcement, but it has lots of implications that are important for us in the healthcare sector as well as just for our families and how we live. She's led the state's Green Infrastructure and Sustainable Landscapes program hosted by the Botanic Gardens of South Australia, the Inspiring South Australia program hosted by the SA Museum and Habitat Restoration Projects, and she's got a background in arts and science and a PhD in ecological literacy. So, Sharon, thank you very much. I know you're our last speaker. You've got actually not a bad audience, and I hope I've given enough excitement that we'll all stay and listen for it.
Thanks very much, Anu, and thanks very much, everybody. Oh, better get on here. I am a clinical trial coming to speak to you guys, let me tell you, because the medical profession would have been the furthest from my list as a child. I have very low blood pressure and blood, I'm gone. So this is a really first time I've ever spoken to a predominantly health audience, which is interesting. So I've also got a prize. I haven't quite decided what the prize is for yet, but by the end I will know. So someone will take home this very beautiful leptospermum, which is a tea tree, a native plant. I think it's a small one that I got from State Floor this morning. However, I'm going to tell you a story about Adelaide National Park City, which is an initiative spearheaded by the Green Adelaide Landscape Board. And it's a story in 3 parts. But to start with, to get my baseline, I'm going to ask a couple of questions. Show of hands. Who here has heard of Green Adelaide? Oh, wow. Okay, so I think we're just over 50%, so that's a really good number. Who's heard of Adelaide National Park City before today? Maybe a little bit less, so maybe just under 50%, but they're just still pretty high. And who's heard of the terms green infrastructure or living infrastructure? Oh, even less. I thought that would be the highest. Okay, cool. So, I think that's my button. So, I'm going to start by setting the scene with a preamble about cities. So the world is increasingly urbanised, and cities are now our primary human habitats. But many cities around the world, most in fact, are struggling to be healthy places. Our world is going to continue to urbanise over the next 3 decades, from 56% of our population last year to about 68% in 2050. And in developed countries, 85% of the population is predicted to be urban by 2040. Now, the biggest impact on the landscape from urbanisation is loss of ecosystems and ecosystem function. Hands up if you know about ecosystems. Pretty well, everyone, so that's good. Ecosystems are what give us healthy air, water, soil, food, medicines, resources, nutrient cycling, climate regulation, and the list goes on. Essentially, all life on Earth, including humanity, depends on healthy, functional ecological systems, however big or small, or wherever they may be, from those inside our stomachs to the Pacific Ocean. Ecosystems can be of any shape or size. So urbanisation has many negative effects on human health, as you would know, physical, mental and social. And here's a list of some in no particular order. It normalises sedentary routines, increased environmental pollutants, contributing to a rise in chronic and infectious diseases. Built environments often contaminate waterways and create excess noise, light and air pollution, which have strong associations with allergies, cancers and mental health disorders. More than 7 million people die each year in the world from air pollution. And I have been to Delhi and I have been to Wuhan, and it's not nice. The abundance and diversity of microbiota is reduced in urban environments, leading to compromised immune systems. So we lose biodiversity in our plants and animals, and we lose the microbiota too. Urban landscapes also generate urban heat island. Is everyone aware of what an urban heat island is? Cool. Warm. Which is an effect attributable to heat generated by human activities and sunlight absorbed by dark and impermeable surfaces like concrete. And this is exacerbated by lack of vegetation and water. And so that heat absorbed in the daytime is slowly released in the evening and night. And then urban food is largely ultra-processed, so we have diet-related health risks. We have urban mental health disorders on the rise. And of course, climate change is a foremost urban health threat and risk, with more extreme weather events and those consequences. So many human health problems are exacerbated where there's a lack of accessibility to nature and green spaces, and the lack of opportunity to engage with nature. Conversely, living near green spaces and natural environments typically brings numerous health benefits, physical, mental and social. And these are well documented. So I'm not sure if you're across the World Cities Report 2022 by the United Nations Human Settlements Program. Anybody come across that? So that's very recent. It stresses that in the face of the challenges of urbanisation, building resilience must be at the heart of cities of the future, and that the success of cities, towns and urban areas will largely depend on the policies that protect and sustain everyone. That we need green investment for sustainable consumption and production, responsive and inclusive urban planning, prioritisation of public health, and innovation and technology for all. And after the pandemic, which is not really completely over, but the bulk of it, I guess, is, when there was a temporary global fleeing to smaller towns and the countryside, cities are growing back. And there's a broad consensus that urbanisation is a powerful 21st century megatrend. But also that we need to build back better. What we had was in many ways unsustainable, and cities now need to address a cocktail of challenges. So the report makes for both sobering and inspiring reading, and to be honest, none of it is new. We've known for a long time cities are in trouble. We've known for a long time cities are growing rapidly, taking up more space, and that the future of humanity is increasingly urban. That the twin crises of climate change and the loss of biodiversity are serious threats to cities and their people. Thus, people have known that we need a new vision for cities, and it's pretty well agreed now that nature-based solutions must be a part of the inclusive planning processes. We've learnt a lot. We know the value of science, that's acknowledged. COVID's, in a sense, even brought that to light, and knowledge and innovation, but we now understand the value of nature. And COVID demonstrated this globally. The need for nature spaces in cities has been shown to be highly important to human health outcomes in many ways. So there's a focus now in the environmental management world on ecological restoration. And a new paper in The Lancet just come out discusses how ecosystem restoration is integral to humanity's recovery from COVID-19 and can be a core public health intervention if it's integrated with socioeconomic, health and environmental policies. So this is in fact the United Nations decade on ecosystem restoration that we're in now, in response to the possibility that 95% of the Earth's land could be degraded by 2050. So ecosystem restoration is the repair of degraded ecosystems and be considered a public health intervention for a number of reasons. It enhances the provision of ecosystem services, It improves engagement, connection with nature, and it can improve social equity in access to nature. And these images are from around Greater Adelaide, to make us feel better for a moment. So there's so much research and evidence supporting the value of nature in cities that it's hard to know where to begin. Urban nature is not very often the same as national park nature, as you would know. So I'm now going to move on into the second part of this story. Urban nature can be green infrastructure, living infrastructure, green and blue spaces, whichever way you want to describe it. They're all very similar. I prefer living infrastructure because green infrastructure tends to incorporate certainly the green, the plants, and the engineering side of things like water-sensitive urban design and green roofs and walls. But if you say living infrastructure, then we take in automatically the concept of other life forms like wildlife. It can be made up of linear parks, of home gardens, of community gardens, of leafy streets, of wetlands, of rivers, of creeks, of beaches, of green walls and roofs, of pocket parks, of verges, of reservoirs. It's made up of plants, animals, water, soil, microorganisms. So I hope that gives a very quick summary of green or living infrastructure and what we're talking about here. It's basically all life forms and the things that support life. So it's acknowledged that we need to bring more nature into cities, but how do we go about addressing the challenges of doing this? How do we address the social inequities, the ecosystem dysfunction, the lack of connection between urbanised populations and nature, the public health issues? So this is all the work of Green Adelaide, which is the landscape board that manages the 17 metropolitan councils and the environment of those places. And these are all images taken in Greater Adelaide in June this year and help to illustrate some of the many types of nature and activity in the city. And I'll tell you why June in a minute. So, what is a national park city? It's a vision for the future of cities. It doesn't address all the issues I've raised, but it addresses a number. National parks are places where people have special relationships with nature and culture. National park cities are not national parks, but are inspired by them. So this movement is not about having cities full of national parks. It's about bringing elements of the relationships people have with national parks into cities. The journey began in London some years ago with discussion about the future of cities. And this movement imagines an alternative future for cities and surrounds, and it asks what-if questions, such as what if we had a better relationship with nature? What if everyone had access to high-quality green space, blue space? What if our streets were greener and we had more birds in our cities? So the vision is to make cities rich with nature, places where people and nature are better connected. And surprisingly, nature was long considered an optional extra in cities. Basically, get rid of everything and plonk a concrete infrastructure on top and grey infrastructure. But now it's acknowledged to be essential for many reasons. So the National Park City Foundation was created to take the world on a journey to transform cities to be greener, healthier, wilder, fairer, and more resilient. And together with World Urban Parks and the Salzburg Global Seminar, the first National Park City was London, declared in July 2019. Why Adelaide? We're the second National Park City in the world, because back in October 2018, Adelaide hosted the second International Forum on National Park Cities and contributed to the development of the Universal Charter for National Park Cities. So we were intimately involved from the beginning. And South Australia's then Minister for the Environment and Water and Green Adelaide's Director attended the launch of London in 2019, and at the same time accepted the baton for Adelaide to become the next. So about a year ago, I came into the role and I was brought on to sort of coordinate our submission and application process. And it was very rigorous, might I tell you, but we were finally rewarded and our new status was announced on the 10th of December last year. And the Foundation's aim is for 25 national park cities by 2025. So becoming a national park city was quite a process. The Foundation produced a journey book which describes the steps and the 23 criteria for achieving this status. We're actually the first city to have undertaken this status because London, in a sense, invented the concept, declared themselves, and then we became the first city to take the, I don't know what to call the process really. But we listened, we learned, we met with people, we workshopped ideas, we advocated, we engaged with the Ghana leaders, many community sectors, local government, industry. We had to develop a website and gather support. We brought together the like-minded of these 23 criteria into chapters and we told our story. We identified our challenges, we collated supporting evidence, we sought local support, community thoughts and youth voices as well. And we searched for great images, we made maps, and this was all supported by the Ghana community, the Ghana elders, the local government, and some of the agencies of state government, and by diverse parts of the community. And the 23rd criteria is actually the creative portfolio, which is this beautiful document. Very proud of it. Which actually formed the basis of our submission. Of course, there was a lot of other things that we had to do, but this is the basis of it. It's on our website, adelaidenationalparkcity.org, but I've brought 6. It's all I could carry along with the prizes and the other things. If anyone's really interested in having a read and you like an actual hard copy, we've got 6 of those and you're welcome to take them. But it is a story of how we've become a national park city and what our evidence is and what we promise for the future. So one requirement was the creation of a charter, so based on the Universal Charter. And this also was created through an engagement process with all those same groups, Ghana Mayurna, NGOs, business, local government, etc. But it describes our vision and it guides us in working together to achieve our goals. But it also promotes sharing and celebrating what we have. And Adelaide is a beautiful green city in many ways, but definitely we're not there yet. So it's important to know that we didn't become a national park city just because we have some fabulous parklands and national parks and waterways and local parks. We're a national park city for many other reasons. Community is critical, and fundamental to our submission is the relationship with community. We needed to demonstrate strong support and also from government. We gathered around 2,300 signatures on our website of support from the community, and we also conducted an independent poll. But you can see on the charter here, these are the things that we have agreed to work together for. Then the whole month of June was a celebration of Adelaide becoming a national park city. We had 160 events outdoors, indoors and online. Could I have a show of hands for anyone who knew about that or participated in any of them? It's very difficult. It's nobody, that's nobody. That's a 0%. I'll remember that one. So it began with our Ghana event at the Warraparinga Wetlands, which had about 500 people attend, and all the images on the top are from that reconciliation event, from Reconciliation Week. Then we had a lot of walks, a lot of talks, cycles, kayaking on the reservoirs, a lot of planting. Of course, June is a great planting time. Gardening, food. We had nature art classes, geocaching. We had webinars, performances, exhibitions, story times in libraries for kids, and a whole lot more. So this was about engagement, involving many people in many ways, educating, bringing people and nature together. We spanned all ages and we spanned many cultures. And this just shows some of the activities. There's a beautiful mandala that was at Brighton Beach that was made by an artist there. And our final official event was the launch of the artwork, the Adelaide National Park City's bespoke artwork at Gate 19 Adelaide Airport. So a young local artist, Lucinda Penn, in the purple, she developed this for the creative portfolio, in fact. And it's so delightful that it's become a focus in our identity and our communications. And she and her partner Harry painted this on site at the airport throughout June, and then it was launched right near the end of June. Has anyone seen this at the airport? Wow, we've got about 4 people have. So that's great. But when you do travel in and out of Adelaide, have a look at Gate 19, because it's 13 metres long by about 3 or 4 metres high. It's huge. And it's a beautiful illustration of Adelaide National Park City. So some of the questions. Where exactly is Adelaide National Park City? Well, if you have a look on the slide there, the green line encompasses all the 17 metropolitan councils that make up Green Adelaide. The stars are all the little conservation parks, different parks, not pocket parks, but the bigger ones. And then the pink line is the Ghana Native Title Claim. And so Adelaide National Park City doesn't have a hard boundary, it has a soft boundary which is somewhere between those 2 lines. So people into the hills, if they're not part of the Green Adelaide 17 councils, can still be part of Adelaide National Park City. You'll notice also it goes out into the marine environment too. So it's a soft boundary, bigger than Green Adelaide and within the Ghana Native Title Claim, essentially. So our challenges. So this was interesting. This was a very thought-provoking aspect of the assessment process, was acknowledging our challenges. So it was very inspiring to identify and document the wonderful things about Greater Adelaide, such as our nature and arts festivals, our green spaces and our waterways and our linear parks and reservoirs, and our beaches, and the actions of many to protect threatened species, and some of the beautiful gardens and the brilliant organisations already working to engage people in nature, such as Trees for Life. It was more awkward to properly articulate the challenges. But the challenges are things like this. What the term national park means to people in Australia, and so that confusion between what a national park city is. We're stuck with that name, but that's why I've explained it to you carefully today, I hope. The destructive effects of colonisation on land and people. Genuine reconciliation with First Nations. Urban development, modification of the landscape, loss of ecosystem function, loss of trees and vegetation. And we're still dealing with that, of course. Impacts of climate change, heat, bushfire risk, water resources. The quality of green and blue space and canopy inequity. And I know we talk a bit about inequity, but the canopy in suburbs in Adelaide ranges from a 3% canopy to a 70% canopy. That makes a massive difference to the quality of life and the amenity and the shade and the temperatures of different places. Irritation with government over planning laws, changing political and economic agendas, the nature of cities generally and a lack of connection to nature, and a lack of understanding about how things are connected and how they interrelate and how nature works, which is the thing I did my PhD on, ecological literacy. And of course, the impacts of many of these on public health. And balancing these challenges with being acknowledged as one of the world's most livable cities. So we had to address these challenges in the application, so that's what makes it quite an interesting read. And we need to address them now and into the future. So we became a national park city, and now this is the third part of the presentation. I mentioned some of the challenges. What do we do about them? How does being a national park city help to overcome them? How do we fulfil our promises and work towards fulfilling the vision? Well, there are some key opportunities for us. We can engage sectors around the collective ideal. There can be much more reconciliation with First Nations people. And that Adelaide National Park City is a government-led initiative. In London, it was community-led. Some of the national park cities in the world are government-led, some are community-led. We are working towards being more of a community-led movement. And so, of course, we can engage community and Kaurna leadership in that process. We're currently working on that. And within 2 years, we will probably be a community-led movement. We can explore more sustainable ways of living. We can champion living infrastructure. We can educate and facilitate connections between nature and health, conserve biodiversity and habitat, more opportunities. Engaging the less engaged is an important one. The lower socioeconomic groups, the culturally and linguistically diverse communities, and people with disabilities, and senior people. Foster delight in gardens, trees, wildlife, growing food. They're very easy things to engage with. Improve ecosystem services, climate resilience. Influence planning and development, and I'll talk about that in a sec. Bringing more science and geographic information systems and innovative thinking into planning and design, and of course providing leadership to other cities around the world, which we're engaged with all of the time. So a look at just some of the things that we're doing. Influencing policy and planning, and using the latest science and technology to help us plan and implement. So we're using GIS technology to develop spatial data and create urban heat maps, tree canopy and vegetation maps that tell the stories of our places, and then using them to inform planning and policy, such as where the hotspots are in Adelaide, the reasons for these, and the relationships between heat and vegetation and water and transportation and the impermeable surfaces and the albedo. And so, for example, this data can tell a story for every hospital, school, or aged care facility about temperature, about heat from surfaces, about shade availability. And sometimes it's a pretty good story, and sometimes it's scary. So there's been a lot of talk over the years about having much more green infrastructure near hospitals and near aged care facilities and schools, because it can provide those cooling, of course, shading, cooling effects, and make it a much more pleasant place to be, to say nothing of using less energy. In Greater Adelaide, we have an average of 23.37% canopy cover, as captured using the LiDAR data between 2016 and 2018. Other capture methods actually rate us as even lower than that. So whichever method is used, we rate as having one of the lowest of all Australian capital cities. Not the lowest, but probably the second lowest, which is quite interesting because I live in a very beautiful green place, and south, it's gorgeous a lot of the places, but there's out west and out north, there's not much tree canopy cover, and the development isn't particularly improving that situation either. So we've got a lot of inequity there, and you can see the influence of lack of vegetation and the hard surfaces make a very difference to the equity of canopy and temperature. So this work leads us to things like this. These images represent a combination of data: urban heat mapping, canopy mapping, permeability mapping, as well as 2016 census data to represent social vulnerability. So it's a perfect example of how spatial data can be brought together to inform policy and facilitate action. This project identifies where the investment in urban greening needs to take place to increase climate resilience, comfort and amenity, and of course access to nature. And we're the very first city in Australia to undertake this metro-wide analysis. So something completely different now. We spend quite a lot of time on communicating and engaging and trying to inspire people. So we've developed 50 ways to be part of Adelaide National Park City. So it's ideas for everybody, whether they're at home or at work or at school or at play. Importantly, one of the foundation's criteria is people must be able to do things on their own, and they don't have to be part of a group or join a community to do things. They can just do things all on their own to contribute. So these are actually A3 posters, which are really good to be pinned to boards or fridges or wherever, and they're quite popular. And I have brought some here today, which are out the front, if you would like to take them. I don't want to take any of them home again, but if I have to, I will. But there's only a few of each, because once again, there was a fair bit to carry. But we've just divided up, so let me just show you. These are the big ones. So these are the ones that the little ones come from. This is 50 ways in English, translated into simplified Chinese, translated into Vietnamese. At this point, we're experimenting with the other languages and what are the most useful languages so that we can reach more people and the less engaged communities, as I was mentioning. And I brought some of these too. So we've got the big posters. These are the A1s, which are great for libraries or for community centres or for big spaces, even in the workplace. You're welcome to take some of those too. And if you want more, just let me know and I can get them to you. How many people have heard of the Nature Festival? Oh, that's another zero. Wow. Was that person? Have you heard of it? Sort of. Oh my goodness. So we do. The Nature Festival's been going for, this is its third year. Last year was quite big, this year's even bigger. Surprising, isn't it? So we support and promote a lot of these kinds of things. And this was launched only yesterday evening. It's happening from the 6th to the 16th of October in South Australia. It's in its third year and it has a fantastic program with over 350 events of all kinds. A bit like our launch. We had all kinds of events, indoor, outdoor, webinar. These are, because it's springtime, I guess a lot of these are going to be more outdoor, quite immersive events for all ages once again. So we support things like this. We partner with a lot of organisations, with local government, with non-government organisations, and we have grant schemes such as the Grassroots Grants and the Greener Neighbourhoods Grants out of Green Adelaide that provide funding to undertake projects to improve local urban environments. And these can range from very large to very small projects. But the book, the one in the middle there, From One Small Seed, is one of the projects we supported and was just launched by Neville Bonney, who was actually one of my mentors when I was at Greening Australia. He's Australia's guru in native plant seed and plant propagation and planting. I think he's probably planted more trees in Australia than any other single person. So this has a vast amount of information and inspiration about native seeds and plants and their ecological and cultural significances. So we support all sorts of projects to improve our urban nature environment. This one's a bit different. We work with education, so we do have an whole education section, not of National Park City, but of Green Adelaide. But this particular example, you would have heard of the Premier's Reading Challenge, and I think, got some nods on that one, people will have kids who have undertaken Premier's Reading Challenge. Well, a few years ago I was in another role and we started Premier's Reading Challenge STEM, and this year we've incorporated STEM Nature into the Premier's Reading Challenge. So the kids, mainly in primary schools, just have to read a book about nature, then they have to be inspired to draw or do a poster or invent something and they send it in. So working with the Education Department, this year we've got some beautiful entries, as you can see there, and we're making a coffee table book out of these entries for the first time as a pilot to give back to the schools, to give back to the students, to give back to, say, libraries, local libraries, so that we inspire even more reading of nature, science-inspired books I must say that even when nature wasn't in the challenge, most of the work was about nature anyway. So we've just really put a name to that. And then, of course, things like participating in things. So this was Science Alive. You would have heard of Science Alive. 20,000 people came to Science Alive this year. We had a stall and 3,000 teachers and students, 17,000 members of the public, families. And we were busy all the time with heat canopy mapping so that people could go in on the computer, find their house if they wanted, and see what the vegetation and the heat issues were there. We had demonstration rain gardens and a tadpole aquarium and laser heat guns to point at different surfaces to see the temperature under the same heat. And so many people were absolutely amazed that the hottest surface of all of the ones that we provided was artificial turf. Say no more. So after the confines of COVID, really people are coming out in droves to participate and learn and enjoy. So this is all under the auspices of the Green Adelaide Landscape Board, and not many people of you had heard of Green Adelaide, some had, but there's a lot of things take place under this Landscape Board, and I don't have time to go into the workings of it, but it does look after the whole of the Greater Adelaide metropolitan environment. So Adelaide National Park City began as a project of Green Adelaide, you know, given that the Minister said, right, we've taken the baton to be the second. A movement to harness the contributions of everyone and a link to the international community of practice, which is quite important, that it's an international movement. But it's also an umbrella that links and promotes all the good things that people are doing. And to be clear, we've only just begun the journey. Green Adelaide is 2 years old, although it was reformed from the Adelaide and Mount Lofty Ranges Natural Resource Management Board. Adelaide National Park City's 6 months old. Currently, we're building relationships with Wellbeing SA, for example. You would know about that, the state government agency supporting physical, mental and social wellbeing of South Australians. The Healthy Parks, Healthy People project, which is a nature-based approach to promoting population health. I'm finding out about numerous health-related businesses and initiatives which are out there using nature-based experiences. You might have heard of Green Prescriptions, which is a trial that Green Adelaide has run about prescribing certain nature-based activities for certain conditions. I don't know if that's the right word, conditions. We're also developing, as I mentioned, a community-led governance framework, and we're talking with many other cities around the world all the time. So, more images from our launch month. Really, to summarise, Adelaide is a national park city because we've agreed to work together to create a city and beyond which is rich with nature where people are actively engaged. And it's so important that cities and urban places improve the way habitat is created for both people and other life forms. We don't exist without those other life forms. Here we have a new opportunity to promote the value of nature, of being in nature and working with it rather than against it. We have a chance to refocus our efforts to make things more collaborative, equitable and inclusive. We have very good reason to use the latest and most effective science and technologies to help us. We have very good reason to highlight the value to public health. We know there's a will, so now it's up to us to identify, innovate and activate the ways. There are fantastic opportunities, we just have to grasp them. This is our full artwork. You can see that it goes from the Aldinga Wash Pool there on the right, right through to the Northern Plains, and if adults and children alike love finding some of the icons in here. Our comms team leader insisted we have the Moles Balls. Well, that's there. I insisted we have the glass of wine. That's there. We've got the St Kilda Adventure Playground, you'll see. The 3 main roads coming in and out. The leafy sea dragon, of course, is our marine emblem in South Australia. We have the dolphins in the Port River. So, you know, it's just fun to play with. It's not just about nature in cities. It's as much about the people and the opportunities for diverse parts of the population to be involved. In fact, our byline is everyone, everywhere, and every day. And I hope this has helped enlighten you about what we're doing and why, because I think the potential for positive change locally and globally is really exciting. According to the United Nations World Cities Report, we must start by acknowledging the model of urban development leading up to 2020 was in many ways unsustainable. We need to reduce inequality and poverty, foster productive and inclusive urban economies, invest sustainably to promote clean energy and protect ecosystems, and prioritise public health. We need to bring nature back into cities. We hope we can make a difference, starting with our own city while talking with many more. Thank you.
Okay, look, thank you so much, Sharon. I really appreciate it. I think it's a great way to finish our week here. I'm just going to open up for any questions or comments from people here. I've got one up the back there, Petra.
I just wanted to say thank you. That was fantastic. I think particularly since COVID, the 1980s has come back with indoor plants. So it's absolutely wonderful that we're going down that path. I mean, in our own division, in our executive suite, we have quite a few plants and lots of plant competitions. But I suppose it's the question that I wanted to ask is, have you done any work with healthcare facilities, like as in tertiary facilities, and how we can become part of this? Because I think, particularly for Sarlan, we've got some new health service planning happening. I've got some work for my division happening down at the precinct, and it's sort of just making me think, how can we integrate a lot of this information that you've presented today? Because otherwise it's going to be a missed opportunity.
Oh, absolutely, and I appreciate that question. And so I think we can meet and get together and discuss what the opportunities might be that suit you guys and that we can help with. I mean, we're making a lot of connections with health providers at the moment of all kinds, and whether you can start by putting up the posters in your workplaces about how to be part of Adelaide National Park City, and then doing some of the things that are on those. But I think there's a lot more that could be done if we were to sort of get together and nut out a plan of something that would work for you. There's things I won't have thought of. Yeah, I'd like to do that. So please, let's do that.
I was recently in Perth, and one of the nurses that was at this conference I was at, her role was climate health and environmental sustainability lead nurse. Which I thought was pretty cool. So have you seen anything like that being sort of discussed
No, I haven't.
at Wellbeing SA, like a
No.
clinical role that is directly related to sustainability?
Not a clinical role that I've noticed, no. But then that doesn't mean there isn't one. I know that Healthy Parks, Healthy People are doing a lot in the space. I mean, I don't know exactly what. I'm not quite up with it yet. There's walking strategies. There's all sorts of other things that are being developed. Green Adelaide is developing the urban greening strategy, but as far as a clinical role goes, I'm not really familiar. But that would be fun.
Just while people think of any other questions, you mentioned that there were green and not so green areas.
Mm.
What sort of temperature differences do you think we might expect to see there? Because my understanding was, that the CBD of Adelaide, if we didn't have parklands there, would be quite a different temperature on those hot days.
So, look, it's been shown that you can have a good 12-degree difference if you have irrigated grass under trees than what's next to it with no trees or no grass. That's a big difference. Even if you don't have irrigated grass, just having the shade of trees and the living plants, shrubs, grasses, surfaces improves, and water even nearby. Massive differences in temperatures, and the other thing about that is that the air moves, so the breezes moves the cool air around. So the more of now a friend, Greg Ingleton, he has a business now called, he was with SA Water, he's with Sydney Water and has a business called By Nature, is doing a lot of research work into the effect of irrigated grass. And the temperature differences are actually amazing, so that if we can use recycled waters and other sorts of, sustainable ways of making our landscapes greener and damper, we get a huge effect. But even just having trees, even just having eucalypt trees that we don't water, brings it down by a few degrees.
I think I'd heard that if you looked at the energy consumption to do exactly what you're talking about compared to an air conditioner, we were actually saving energy by growing things, irrigating grass, using all those sorts of things. So it's an amazing effect when we talk about it on those particularly hot days.
It's not only the temperature, but I mean, as you were talking about before, the absorption of the particulate matter into green leaves, and there's some species that are particularly good at that, is quite significant in terms of air pollution.
Got one more question here.
Thank you. I'm feeling very optimistic, but there are reasons why we might not also feel optimistic. First of all, I think, the work that Andrew presented showing that particulate in the air affect our health, it's obviously not just hearts and lungs, but it's everything. So I work in pregnancy, and there's a lot of data showing that women who live in these mega cities have much higher rates of preterm birth that are associated with cytokine storms in their bodies, so lots of inflammation. Pregnancy is already an inflammatory state. The 2019 bushfires in Australia showed much higher incidence of preterm birth. The map you showed of Greater Adelaide, I don't know if you've been. I took our grandchildren on the train down to Seaford, and we also went on the steam train to go out to the Bugle Ranges from Mount Barker. And all those new homes that our young people with young families are living in, they have about 1.5 metres of ground around them between each of those homes.
It's terrible.
So that takes a big, bold, courageous statement by government to actually address that sort of development that our young families are essentially forced to live in. A lot of us here live in much bigger homes, bigger blocks. Some of us have country residences. We are much more fortunate. But what is involved, you've got government on your side, obviously, but what is government going to do about development that is about making money for developers that really goes in the opposite direction of everything you're proposing? I don't want to be negative.
No. It's a fact.
I'm also old enough, and you probably are too, to remember Bob Hawke saying there were going to be 1 billion trees planted, and the rabbits in this country ate far more than the 1 billion that were planted in that 5 years or whatever. So it takes a lot of courage and a lot of drive.
You're absolutely right, but I can tell you that we, in the last few months, just this year, there have been many forums with the development industry, with Green Adelaide, with the development industry, with local government, trying to address those problems and bringing the discussions to the fore. And the development industry has always been a very difficult beast to bring into the conversation. Years ago I was working with the Botanic Gardens and the Green Infrastructure Program, and we worked with Renewal SA, and some of their developments were really good, really green, and others were not. So, it depends how much money they want to make or spend, or, it's I hate to say it, but I think it's about money. But we're working with the development industry, and we're working with the planning and infrastructure departments, and I think this is going to change. We're also working with Department of Transport, because they refused to put trees in median strips for many years, despite the fact that some of our best, most beautiful streets have got trees down the middle, and it provides some shade and some beauty as well. And of course, protection from the sun and from wind and habitat and all of the things. So I can tell you that it is on the agenda and it is happening. The conversations are happening, and I'm very hopeful that they're going to lead somewhere in the next short while.
Sharon, thank you very much.
Can I give my prize?
Well, I've got a suggestion for you.
Oh.
Bear with me. So I'm going to get you to give the prize to Simon in lieu of somebody else, right? So they're here. Sarah's here, is she? Oh, fantastic. So we've been using an app called the Hoover app, and all of this has been online this week, and we will download all of the talks so that they'll be available through the research office if you would like to, and we'd like you to use them for every purpose that we can. On the Hoover app, we've had lots of people connecting with each other, putting up comments and so forth, and so last year we had the Broken Thumb Award, and this year we've run that again. This was for the most comments and most postings, so we thought that this might be a good Green Thumb, Broken Thumb Award. So I think Dr. Sarah Tomasi, is Sarah here? Come on down. Congratulations.
Thank you. It was fun.
Good. Excellent. We need to know what your tricks are as well.
I don't have kids, so when I'm at home, I've got enough time to go and play with the app and comment. But also, I found a lot of the conversation very, very interesting, and I think that bring it together, the perspective. I've been doing research for a few years, and so I was trying to put out there some suggestions and some exchanges of opinions with people, and it was actually a very productive exchange most of the time, so it was very good.
Thank you, Sarah.
Thank you.
Thank you so much. So I hope that's okay.
Sarah, you get the prize. Oh,
thank you.
I think it's
Hannah.
and that's paper.
That's
Yeah.
okay, I'll go out and back it.
Thanks so much. Look, just in closing, and thank you everybody who stayed here and anybody who's online. Thank you for hanging in there with us. I know it's a really long day on a Friday and everybody's pretty keen to head into the weekend or whatever else they've got to do. I won't take too many minutes. I really just wanted to get you to help me thank our research office, led by Simon Winter. Constance has been incredible. The work that we have done to put this together, you've seen. It's been quite a program of effort for us, been very productive. I think everybody's enjoyed doing it, but I wanted to thank them and ask you to help me thank them as well. And if you've got any suggestions, get online, drop into the office, let us know, because we'd like to know how to do this better again next year. So thanks so much, everyone.